Check, test. Check, test.
employability, holistic training, artificial intelligence, sustainable development technology, medical sciences, law, agriculture, and engineering. Employability, holistic training, artificial intelligence, sustainable development technology, medical sciences, law, agriculture, and engineering. employability, holistic skill training, artificial intelligence, sustainable development technology, medical sciences, law, agriculture, and engineering. Employability, holistic skill training, artificial intelligence, sustainable development technology, medical sciences, law, agriculture, and engineering. Global employability, holistic skill training, artificial intelligence, sustainable development technology, medical.
Good morning, everyone. We would like to extend a warm welcome to our Pro Vice Chancellor, Reverend Father Baby Joseph. Now, I would like to welcome Dr. Dean of KMMC, Professor Dr. N. Mohan. Our Director, Dr. Allegason. Vice Principal, Dr. Ashok Kumar Sir. Father Jnana Pragasham. And finally, Sister Pascal. We, the Department of General Medicine of Kanyakumari Medical Mission Research Center, Medical College and Hospitals, Muttom, and the Research Society for Study of Diabetes in India, with the blessings of the Most Reverend Father Dr. J.E. Arulraj, Chancellor of St. Joseph University and Founder Chairman of DMI and MMA Group of Institutions, welcomes you all for the CME. Diabetes is a complex disease that presents unique challenges to the patients and the healthcare professionals. That's why we are here today to deliver info on latest advancements in diagnosis, treatment, and management of diabetes mellitus. We extend our heartfelt gratitude to our organizing chairman, Dr. Anthony David, Medical Superintendent of KMMC, Muttom. Organizing Secretary, Dr. Prince Pius, Professor, Department of General Medicine, KMMC, Muttom. Organizing Treasurer, Dr. Tambidure David, Deputy Director, KMMC, Muttom. It is now my distinct honor to invite our beloved Dean, Professor Dr. N. Mohan, to deliver the welcome address.
Good morning, everyone. First and foremost, I would like to express my gratitude to each and every one of you for taking the time to join us today this program. We all join together for this CME diabetes update with the blessings of the Most Reverend Father, Chairman, Chancellor of 4 universities and founder of DMI, MMI, AMI group of institutions, Most Reverend Father Dr. J.E. Arulraj. I am honored to welcome our Pro Vice Chancellor, Reverend Father Baby Joseph, and I would like to extend my welcome to our DMI sisters, MMI fathers, Director Admin, Director Legal, Director Academics, Medical Superintendent, Vice Principal of Medical College, Deputy Directors, Medicine and Surgery, RMOs, Principal of Nursing and Pharmacy, Vice Principal of Allied Health Science, faculties, and my dear professorial colleagues and professors from Government Medical College and Sri Mugambika Medical College and consultants and dear IMA doctors. I also appreciate the hard work and dedication of our organizing committee. Special thanks go to the organizing secretary, Professor Dr. Prince Pius, and the organizing chairman, Anthony David, and organizing treasurer, Dr. Thambidure David, who have worked tirelessly to make this event a very successful. I want to express my gratitude to the eminent teachers who are going to present today. Professor and HOD of Medicine, Kanyakumari Government Medical College, Professor Dr. John Christopher. He is senior most professor, and Professor of Medicine, Sri Mugambika Institute of Medical Science, Kulasagaram, Dr. Tilagar. Welcome, sir. Consultant endocrinologist, Dr. Joel Franklin. Consultant physician, Dr. Arti Kannan. Welcome, madam. Consultant diabetologist, Dr. K. Sudhagar, and Jairam Kosalram, Assistant Professor of Medicine, and our Dr. Beloved, our Professor Prince Pius. Welcome, sir. As healthcare professionals, it is our responsibility to stay updated on the latest advances in diabetes care and management. The CME program aims to provide a platform for knowledge sharing, discussion, and networking among experts in the field. The CME program is an excellent opportunity for us to come together, share our experiences, and learn from each other. As we gather here today, we are reminded of the growing burden of diabetes worldwide. Students, can you tell which day is World Diabetic Day? Yes, very good. Our students are very brilliant. Diabetes remains a growing global health challenge affecting millions worldwide. As of recent analysis, over 800 million people worldwide are living with diabetes, a figure that has more than doubled in the past 30 years. In India, the highest number of individuals with diabetes globally, with an estimated 212 million people affected. Notably, more than 50% of the individuals with diabetes in India are unaware of their condition, leading to potential complications if not detected and managed early. Increasing incidence, recent studies indicate rise in type 2 diabetes cases among individuals under 20 years of age. This surge is contributed to combination of genetic predisposition and environmental influences, including sedentary lifestyles and high-calorie diets. Type 2 diabetes is a multifactorial disease influenced by both genetic and environmental factors. High concordance rates in identical twins and familial patterns undergo the genetic component. The transition towards high-calorie diets rich in sugars and fats has been a significant driver of the diabetic epidemic. Sedentary behavior contributes to obesity and insulin resistance, further elevating diabetic risk. The urbanization, socioeconomic status, lower socioeconomic status is associated with limited access to healthy foods and health care, increasing vulnerability to diabetes. Diabetes can lead to severe complications such as blindness, kidney failure, heart attack, stroke, etc. A new global survey conducted by the IDF, that is International Diabetic Federation, reveals that 77% of people living with diabetes have experienced anxiety, depression, or another mental health condition because of their disease. As an educational institution, we have a responsibility to educate our students and the community about diabetes. We can do this by organizing awareness camps, health screenings, and educational seminars. By spreading knowledge about diabetes prevention, early detection, and management, we can help reduce the impact of this disease. Prevention diabetes is possible through healthy lifestyle choices, encouraging regular physical activity, maintaining a balanced diet, avoiding tobacco use, and reducing alcohol consumption are key steps in preventing type 2 diabetes. For those already living with diabetes, proper management through medication, regular monitoring, and lifestyle adjustment is crucial. I encourage you all to engage actively, ask questions, and share your experiences. Let us work together to improve diabetic care and management and make a positive impact on the lives of our community and patients. I wish you a productive and enlightening day. Let us begin the program. Thank you, one and all. Thank you very much.
Thank you, sir, for your warm welcome address. We would now like to invite Reverend Father Baby Joseph, Pro Vice Chancellor, Professor Dr. N. Mohan, Dean of KMMC, Dr. Surendran, Director of KMMC, to come forward and light the ceremonial lamp. With the blessings of Reverend Father Dr. J.E. Arulraj, Chancellor and Founder Chairman, we would like to move on to felicitation by Pro Vice Chancellor Reverend Father Baby Joseph.
Good morning to all of you. If I want to start now, pin drop silence should be there in the hall. Pin drop silence. Yes. For me, I am first time in this institute on the dais here in front of the medical students. I am Reverend Father Professor Dr. Baby Joseph. I was also a Dean Research in the other universities. I was also Vice Chancellor in charge in 2 other universities. And I am also a delegate of India to European Union. I am also a delegate to Commonwealth Ministry of Education and Chairman for Asian Confederation of Science in Singapore. And I am also coordinating the health sciences and other things in connection with the World Health Organization, and I am also advisor to that. I have done a lot of researches in, I prepared a lot of vaccines, not a lot, 4. And then I have got awards for the same by WHO. So significant contribution I have done. I have got a publication of 176 and my agenda is 39 in Web of Science and 67 with Scopus and so on. It goes on like that. And I have guided 25 PhDs, 18 of them are in abroad. I have started a 14 Center of Excellences. So like that, I have my own credentials, just for your information. All these credentials are a summary of smart work and hard work. If I could do this, you can also do the same. So try to focus on your area and study well and go ahead. Come out with a significant contribution, not come out with a degree that is a bachelor's degree like, but come out with a degree and a professionalism which will launch with a significant contribution. As an introduction for the same. I'm very happy to be here in presence of the directors, dean, and coordinators, professors, and also the medical doctors from other medical colleges and institutes, and the medical students of our KMMC. Welcome to this August gathering for the conference on diabetes. I just would like to recall to your mind the body metabolism. You know, what is the meaning of, when the term comes to your mind that metabolism, what is that? Anybody can tell? In 2 words. Great. That's right. So both the catabolism and anabolism is happening. Catabolism means a breakdown process. Anabolism means a building a process. Okay. So this is what is happening in the metabolism. The breakdown process has to happen at the beginning. Then only the building a process will happen. The functional thrill of that particular thing will happen only when breakdown is happening in the proper way. And the famous Dr. Paul Langerhans in 1868 found out islets of Langerhans. Islets of Langerhans where no a cluster of cells are present inside. So a cluster of cells together he put it as one term after his name, islets of Langerhans. This islets of Langerhans is having three cells. The alpha cell, the beta cell, the delta cell and the gamma cell. You know very well that the endocrine system is producing hormones in such a way that to make the metabolism with to keep it in homeostasis, with a balance. So, beta cells produces insulin. The amount, the volume is very high, 70%. 70% insulin is produced by beta cells. And the alpha cells is producing glucagon, you know, that is 20%. See, 70 plus 20, 90. Then again 10% is there. The 10%, the delta cells, somatostatin is produced, which is less than 10%, mostly 5 to 7. Then the PP cells, pancreatic, what is that? Polypeptides, which is less than 5%, mostly 3. So, altogether 100%. These cluster of cells are responsible for the breakdown process in the metabolism. Mostly, that means regulating the sugar molecules in the body. If it is not properly broken down, inactive secretions and accumulations will happen. Then we may be slowly developing our patient stage, unhealthy or ill health stage. So therefore doctors are telling, see, some diabetic, mostly the diabetes earlier times doctors were doing the pedigree analysis, where it's a hereditary, a transmission from heredity. But later we understood that nowadays the doctors are not strictly keen to that it is inherited, like it's not hereditary, but there are, but it is a lifestyle disease, like lifestyle disease. So for that, in order to, now the health awareness is more than the previous. So from time immemorial, people thought that the lifespan is only up to 55, 60. But now the lifespan in India is 82 and 84. 82 for gents and 84 for the ladies. Why it is so? It is just because the people have developed a health, a sense of health. Health awareness program is very much personalized by the people. Therefore, they will go and consult the doctors on time, and they will be controlling their own food habits and so on, and dieting and exercise will be done, and people are healthy, more healthy, lifespan is gone up. So we are privileged to live, at least we can aim at 80 to 84 like. That's no problem. But the thing is that when insulin is produced by the beta cells, or the molecules are controlled by the total production of the islets of Langerhans, things are okay. Once the cells are not functioning, then we will take additional measures to enhance the system. Oral intake or insulin injection or maybe tablets. various metformin tablets will be prescribing or taking. That's quite natural. What is happening? Some doctors say, if you take tablet, no, you please take tablet before the food. Some people say after 20 minutes after the food. Okay, it's quite natural. But taking medicine before the food is healthy. Why? Because the medicine interacted with the body systems and involved in the secretion of insulin, and the body will be getting ready to receive the food to catabolize or maybe to bring particles like. So taking medicine early to food is healthy and is desired. Now the thing is that we are having insulin in our body produced, but our system is not able to activate properly. So the receptor organs are there in our body. The receptor organs to be strengthened in such a way that the produced insulin should be absorbed to activate, to catabolize or anabolize. This has to happen. If that is not happen, then there is a problem again. So we have to check both. So people are giving the metformin 500. Once upon a time it was okay, but it's not okay now. People will sometimes prescribe the Istamet 50 per 1000 or 50 per 500 or diamicron, something like that. So what happens is, the Istamet, even in foreign countries also they used to give. Why it is so? Because it is having dual function at the same time. One thing is producing insulin, another is strengthening the receptor organ. So that is the thing. So there are various medicines with the same different combinations and so on, and with the different brand names. But the science behind is this. The physiology or anatomy combined is functioning like this only. So the endocrine system has to be protected and prevented. That is our responsibility. We may be having all these systems inherited from our parents, okay, by birth. But innate or autoimmunity will be there. But still we have to enhance our immune power. Of course, we will have a BCG or Bacillus calmette-Guerin injection in the beginning. It will give you a general protection or resistance capacity in your body, apart from the autoimmune. But still, that may not be enough, because as per the nature of the body, nature of the health situation, nature of the life, lifestyle, it varies. So each one has to take care of their own health and protect your own organs. Therefore, you will live long. This is what I just want to tell you. And now, this diabetes is of two types mainly. Diabetes, type 1 and type 2. Type 1, that is juvenile diabetes and so on is falling into that category. Which is we cannot predict. Unpredictable situations, the hypoglycemia, hyperglycemia, everything will come. People will be very active and healthy. All of a sudden they will fall down, sometimes due to the hypo. And this is a continuous thing. Most of the time it may not be corrected by the oral intake, but it should be corrected by means of insulin injection and so on. And food pattern, timings of the food and everything to be measured and to be followed very much. But type 2 is a so-called, everybody is having a type 2 diabetics. Now that should be corrected. The dieting and exercise and medicine can make a cure or keep a balance only when we are in the type 2 situation. And in general, is the diabetic is a disease or not? Never it is accepted as a disease. This is not a disease, but it's a state. It's a state of the body condition. This is what the medical science says about. And now, since we are attending a conference here and very many experts are going to present before you, and you will have a lot of critical thinking and interactions, discussions, and then you will be taking new measures today. So I'm very happy to, what I say, to partake in this. At the same time, I'm very happy to encourage you people to conduct more such events here. Not only on diabetes, but on many other things. So, you know, diabetes is only one of the elements in our health system, or one of the portions, but no, many other pattern. You will be having symposium, seminars, conferences, then colloquium, all other things I had told your professors to talk out with the faculty members and the students, and there should be a clear vibrancy of a medical science as well as medical studies in this campus. It has to happen, and you have to go with novel things. I just give you some information that, or I advise you that don't go with the syllabus alone. Syllabus of the medical or any institute, any colleges or university syllabus is not, every day it is not updated. The syllabus is given 10 years back or maybe 5 years back, something like that. But no, it is up to you to update. The medical science is going up every day. New findings are coming up. So please go to the website, Medical Encyclopedia, and also go with the people who are doing research and discuss with. Therefore, you are able to come out with you will be a vibrant medical professional in this field. So I wish you all the best. Have a nice day. Thank you for your time.
Thank you, Reverend Father Professor Bailey Joseph, sir, for your contribution to medical field and sharing your knowledge on this grand occasion. We are now commencing our CME session. We welcome Dr. Prince Pius, Professor of Medicine, Kanyakumari Medical Mission Research Center, Medical College and Hospitals, Muttom, who will provide a foundational overview and set the stage for the inter-discussion to follow.
First of all, I thank Most Reverend Father Arulraj, our founder chairman, for allowing us to conduct this program in this institution. And I joined in this institution just 2 months before, and I'm fortunate to work in this institution. And I want to welcome all the doctors who have come from many parts of our district. And as you all know, the type 2 diabetes, as narrated by Dean Sir and our Pro Chancellor Father, it is a very common disease. In the introduction itself, Professor Dean Sir told everything, half of the thing. Next slide. So this is a study published in Lancet, shows that more than 8 million people worldwide suffer from diabetes, of which 212 millions are in India. This is a study published in Lancet. It shows more than 1/4 of the diabetic population in the world is in India. So you young doctors, you want to become a diabetes specialist or some other specialist, because our population, so this is the best field for you. And also not for the dietitian. So now the concept is, that is why we are conducting the diabetic CME here. So RSSDA is the Research Society for Study of Diabetes in India. So our objective is the spreading the knowledge to all the doctors, not only for the diabetic specialist or MD, general medicine specialist, like that. So now the diabetes is treated by all the specialty doctors, even END doctor, the ortho doctor, and OG, everywhere we have this disease. So we should know the basics of this disease and how to treat. Every doctor should know. So this is one study. Next slide. So this is one study done by the ICMR and INDIAB study, ICMR and INDIAB study. In this study, more than 100 million diabetes are now in India, and another 135 million people are suffering from pre-diabetes. That means they are in the verge of getting diabetes. So that is the thing. So more than 25% of our population is at risk of diabetes. That is very, very important message. So we should identify the disease early. See, as professor said, more than 50% is not yet diagnosed. So we should diagnose the unknown cases, and after diagnosis, we have to treat them fully, and they should not develop any complications. That is the main thing. So the statistics says that 70%, more than 70 to 80% of the people will have hypertension and some cardiovascular risk, and 40% of the people develops nephropathy, of which 10% will develop end-stage renal disease. And like that, many amputations are because of this diabetes. More than 10% of the amputations are because of diabetes. So this disease affects all the blood vessels and all the organs. So kidney, liver, everywhere it is affected. So we should know. In this CME, we are going to discuss all these things, and it will be very useful for you. And for the students, after each session, we ask one question. If you answer, you will get a prize. Okay, so you be attentive and listen to all these topics. And I don't want to take much time, and we will start the CME proper. Thank you.
Thank you, sir, for your thoughtful presence. It's a pleasure to welcome Dr. John Christopher, Professor and Head of Department of Medicine, Kanyakumari Government Medical College, Asari Pallam. The topic of discussion will be classification and diagnosis of type 2 diabetes mellitus.
இங்கிருந்து பார்க்கும்போது அங்கே ஒன்றும் தெரியல, ஸ்லாண்டிங்க. Good morning to everyone. So first of all, I thank the organization for giving me this opportunity to talk on the classification of and the diagnosis of diabetes mellitus in this forum. So first I thank the founder, chairman, dean and professor of medicine, Dr. Prince Pace, and Dr. Anthony David, superintendent, and all the faculties and students for inviting me to talk on this topic. So I will enlighten what are the different classification which is given to in the recent times. So diabetes is not a disease, just as chairman said. So it is a disorder of metabolism. Mainly it is related with the carbohydrate, proteins and fat metabolism. So this is occurs in with the deficiency of, this is regulated by the hormone insulin. So if there is any deficiency, absolute deficiency of insulin, or it is resistant to insulin, or action of the insulin is not there by other mechanisms. So we'll start with the first. So diabetes classification, it is divided into type 1, type 2, type 3 and type 4. Another one is called atypical diabetes. So type 1 again subclassified into type 1A and type 1B. So type 1A is mainly due to autoimmune. So autoimmune usually occurs in the population in the younger age group, that is less than 30 years or even 10 years, 20 years. So younger age group, it commonly affects the individual. So usually they have auto antibodies in their blood. Auto and especially mainly to islet cell antibodies or GAD65 antibodies will be there. So this is just an highlight just before. So the incidence of diabetes is not only in the urban population, it is also increasing in the rural population. Another thing is awareness of taking care of the health habits. So early screening and diagnosing early and intervening with this, so we can prevent. So most of the patients present, in most of the cases, that is end stage, they are presenting with the end stage renal diseases, mainly the cause is diabetes. Another thing, increase in morbidity and mortality of coronary artery disease. Major culprit is diabetes. Second one is hypertension. So these are the two major. Another thing, most of the macrovascular and microvascular complication. Macrovascular means acute myocardial infarction, cerebral stroke, and the peripheral vascular disease. These are the macrovascular complications which are commonly produced by diabetes. And another thing, microvascular complication, that is mainly diabetic kidney disease, diabetic peripheral neuropathy, diabetic retinopathy. These are the things commonly you come across. Somebody presenting with the type 2 diabetes, when they reach the hospital, we can examine, suppose there is a hypertension, you screen for blood sugar, it is high, and also renal parameters, when you check, it will be high. They are presenting with full-blown complications of macrovascular as well as microvascular complications. So rural India, there is a expected rate is 128% of diabetes between 1990 and 2013. 109% in women and 126% in man. Another thing is total diabetic population is 7.3%, and another thing is this is going to increase by about 2040. It is almost triples from this 2015, this calculation. So it is 8% according to the new estimates. 72.96 million affected with diabetes. Prevalence is similar among male and females. So highest prevalence is occurred between 72 and 79 age group. Next slide. So types, it is broadly classified in type 1, type 2, type 3, that is a specific type, monogenic, MODY type, and fourth one is gestational diabetes. So I am going to tell certain things about type 1, type 2 and type 3. Type 4 gestational diabetes dealt by Dr. Aarti. So I will leave it that with Dr. Aarti. Next slide. So type 1, I already told you, it is a type 1 is a immune mediated destruction of the pancreas, absolute insulin deficiency, presence of 2 or more auto antibodies, almost seen in 85 to 90% of the people. So mainly to islet cell antibodies, GAD65 antibodies, and zinc transporter 8 antibodies, ZNT8. So most commonly seen in less than 20 years of age group. It can develop at any age. Sometimes 30, 35 years old man presenting with sudden onset of diabetes, and his earlier stages, it is developed, he will respond to sulfonylureas, and suddenly he become resistant to sulfonylureas and he need insulin for the control of blood. That is called LADA, late onset autoimmune diabetes in adults. So LADA. So it can present as atypical present. So we classify it under atypical diabetes. So type 1 is idiopathic. We could not find out any antibodies in their bloodstream. So it may be idiopathic. We cannot find out any cause in that particular type 1 diabetes. Next. So what are the phases of development of diabetes mellitus in this era? First phase is with a normal glucose tolerance. So islet cell antibodies which develops earlier than the patient develops over diabetes. So beta cell mass. So the mechanism of developing this one is auto antibodies which distracts the beta cells. So insulin, there is formation of insulinitis. So that lead on to destruction of all the beta cells and progressively decrease the secretion of insulin. So in this situation, patient will have a maintenance of normal blood sugar even with the low dose of low levels of insulin. That is the phase of normal glucose tolerance. Then another second phase is phase of impaired glucose tolerance. So features of diabetes will not evident even with the destruction of 70 to 80% of the beta cells. So residual functional beta cell, in this situation, residual beta cells cannot maintain the normal glucose homeostasis. Because of that, they develop intolerance to glucose and develop features of diabetes. So third one is phase of frank diabetes. So in this situation, if the patient develops any stress like any infection or even puberty, that can lead on to frank diabetes mellitus. In this, they will have increased fasting blood glucose and postprandial blood glucose and elevation of HbA1c levels. Another fourth phase is on honeymoon phase. Anybody? So initially patient will in type 1 diabetes, they require large doses of insulin to maintain the normal blood sugar. So after a particular period of this, patient doesn't require any insulin for few months or even up to a year. Right? So our patient requires very low dose of insulin to maintain his glucose levels. So after that period, again patient needs large doses of insulin. That period is called honeymoon phase in the stage of developing type 1 diabetes. Next. So what is the pathogenesis? I talk very shortly. It is an autoimmune disease. So genetic susceptibility is more in patient with development in type 1 diabetes. So because it is proved that it is greater incidence in twins affected with than general population. Another thing, greater in monozygotic twins than dizygotic twins. So another thing, so environmental factors also influence the precipitation of type 1 diabetes. If the patient develop some viral infection, especially coccidiosis virus infection or mumps, measles. So these virus infection, if they develop, it will produce again acute inflammation of the pancreatic cells and produces aggravation of this pre-existing type 1 diabetes. So another thing, type 1 diabetes is commonly associated with the genes HLA-DR3 and HLA-DR4 or both will be present. They will be positive in patient with type 1 diabetes. Next. So type 2, coming to type 2. So it is a group of disorder character, variable degrees of, here insulin is available. But the patient will develop resistance to insulin action. Because of that, they develop type 2 diabetes, impaired insulin secretion, insulin resistant, and increased hepatic glucose production. There are so many precipitating factors for developing type 2 diabetes. Most of the people, you aware what are the things which produces. So environmental factors. So main thing is, next slide. So it is a multifactorial. So increasing age is also one of the risk factor for developing type 2. Second one is obesity. When you see obesity, when we were students in the school, at least the whole of the school, we will have one obese student. But nowadays, when you see each class, every classroom, we will have 2 or 3 people with morbid obesity. So because of lack of exercise and the dietary changes, which causes the influence, the development of type 2 diabetes. Then obesity, ethnicity, family history. And then associated thing is a metabolic syndrome. That is also a increase, one of the increased reasons. That is central obesity. They will have hypertension, hypertriglyceridemia, and also low HDL. They are also present with type 2. Then environmental factors. Then sedentary lifestyles. Then dietary habits and associated obesity, and also genetic factors also influence the development of type 2 diabetes. Next. So type 3. So type 3 is associated with specific single gene defects. So this is called maturity onset diabetes in the young. On monogenic diabetes are characterized, there is a autosomal dominant inheritance. There are so many MODY types. Even now it is up to, I think, 30-40 types are there. MODY differentiation of type 3 diabetes. So it is autosomal inheritance, dominant inheritance. Early onset hyperglycemia, it is present again as less than 25 years. Strong family history of early onset diabetes. So there also you can suspect MODY. Evidence of macrovascular complication in the earlier generation, previous generation, if they have macrovascular complication, again also you can suspect. Then there is a sensitivity to sulfonylurea. That is another important factor in patient with MODY, and they are non-insulin dependent. So absence of insulin resistant phenotype. So this is very characteristic features of MODY. Next slide. So it is subclassified into up to I. So 3A, genetic defects of the beta cell development or function. Main common factor which is involved in this type 3A is hepatocyte nuclear transcription factor 4 alpha, that is classified as MODY 1. Then glucokinase, it is MODY 2. Hepatocyte nuclear transcription factor 1 alpha, if it is the reason for defects, which is MODY 3, insulin promoter factor 4, and so on, so on. So this is classified accordingly. It's a type of 3A. So type 3B is transient neonatal diabetes. That is classified under type 3B. 3 is disease of the exocrine pancreas, where it is pancreatitis, pancreatectomy, neoplasia, cystic fibrosis, hemochromatosis, fibrocalculus, pancreatopathy. There is a lean patient, they will have a fibrocalcific pancreatitis, and they develop type 2 diabetes. Next slide. Next. 3D, this is a type A insulin resistance, lubricant syndrome, Rapson-Mendenhall syndrome, and lipodystrophy syndrome. These are all classified under type 3D. Type 3E is associated with other endocrine diseases, acromegaly, gluconoma, pheochromocytomas, so other Cushing syndrome and hyperthyroid. F is drugs and chemicals which are causing type 2, that is glucocorticoids, nicotinic acid, beta-adrenergic, and other drugs, calcineurin, pentamidine, diazoxide, thiazide, and all these are secondary to producing type 3 diabetes. Next. So 3 is infection. It's related with infection, cytomegalo virus, congenital rubella, cytomegalo, and the Coxsackie virus. H is stiff person syndrome, and the insulin receptor antibodies, I is Wolfram syndrome associated with genetic syndromes, Wolfram syndrome, Down syndrome, and Turner. So these are ways you classify type 3. Next. Type 4 is gestational diabetes. So glucose are developing during the second or third trimester of pregnancy. That is second and third trimester if it is diagnosed as gestational diabetes. Suppose if the patient develops glucose intolerance in the first trimester of pregnancy, it is pre-existing, pre-gestational. You will term it as a pre-existing, pre-gestational diabetes. They have either type 1 or type 2. Then finally I told you atypical diabetes. This is comes under LADA. It is coming under this. If antibodies are positive, it is grouped under LADA. Antibodies are negative, it is grouped under type 2 diabetes mellitus. Next. They are ketosis prone. So why screening is necessary in these patients? Majority are asymptomatic and unaware that they have the disorder. Most of the time, so they present to the hospital with some acute problem. There is acute myocardial infarction or acute CVA. When you check, the blood sugar will be around 400, 450. When you ask the patient whether you have either checked your blood sugar or not, they said, we doesn't have any symptoms at all. So we have not checked. But now government of Tamil Nadu and government of India, there is a screening of non-communicable disease. Any patient comes inside the hospital above the age of 25, they have to screen for diabetes and hypertension. Definitely, all cases. So we did a study in our medical college, Kanyakumari Medical College. So almost the population which are asymptomatic, from that we have to find out some 5 to 10% of unknown case, undiagnosed cases of impaired glucose. Their random blood sugar will be more than 200. When we will, then we will ask them to come for a checkup for fasting and postprandial and for HbA1c. So in that situation, almost 7-8% of the patient without symptomatic we diagnose as diabetic. And also hypertensive also it is diagnosed very early because of the screening. But when you ask the patient, they will have no symptoms at all. Even when you prescribe medicines, they will not take. Because they will say they don't have any symptoms at all. But we have to educate the patients. Once you develop symptoms, it is a terminal stage of your hypertensive disease. So once the brain will tolerate till as much as possible. If it is not able to tolerate, then only it will produce symptoms, headache or headache, vomiting, or with dizziness. All these symptoms will occur only in the late stage, or straight away they present with macrovascular complication, either acute pulmonary edema or acute myocardial infarction or CVA. Then type 2 present for up to a decade before the diagnosis. Suppose if they present into the hospital with full-blown type 2 diabetes, when you diagnose, they will have features of either microvascular or macrovascular complications. Then treatment may be invariably alter the natural history of the disease. Even nowadays, it is the talk of the diabetologists, reversal of diabetes. Suppose if you follow the diet adequately, if you exercise regularly, even without medication, you can control diabetes. That is a reversal of diabetic reversal. So you can prevent so many complications if you diagnose early and treat the patient. And if there is a comorbidities, which are the cause for even type 2 DM, you have to address to the thing. Mainly obesity, you have to reduce weight, other habits, smoking, alcohol, everything you have to stop and moderate. Then regular exercise, that is also very, very important. Next. So these are the people, I already told you, some people you have to screen definitely for type 2 diabetes. So if you have a previous history of impaired glucose tolerance, then every year you have to screen the patient for the development. Suppose if there is a obese, you have to ask the patient to reduce the weight, then regular exercise and dietary habit, they have to change. If it is not controlled with, then advocate medications. Next. So what are the criteria screening for type 2 diabetes mellitus in adults? Any overweight patient, BMI more than 25, Asian American and other ethnic relevant definition who have risk factors, family history of diabetes, definitely you have to screen the siblings for type 2 diabetes. Race, ethnicity, hypertension, then low HDL cholesterol level, polycystic ovarian syndrome or acanthasis nigricans. If the patient having these things, you have to screen for type 2 diabetes. History of cardiovascular disease, physical inactivity. So other factors associated with the insulin resistance, that is obesity, again acanthasis nigricans. Next. So previously patient presented with IGT or impaired fasting glucose or HbA1c between 5.6 and 6.4 should be screened annually. Every year they have to do. Women who had gestational should be screened at least every 3 years. So most of the people after delivery, their blood sugar become normal. They won't have any follow-up. Then again they present with either ketosis or other complications of diabetes. So individuals with HIV. So this 45 years now reduced to 25 years. Anybody above the age of 25 years, you have to screen for diabetes. Next. So diagnosis, how will you diagnose diabetes? So one is random blood sugar level more than 200 with classical symptoms of diabetes, polyuria, polyphagia and polydipsia, or marked weight loss, you have to think of diabetes. Students, any other condition which produces increased appetite and weight loss? Anybody? You are first year, but anybody? So you have to think of hyperthyroidism also. Patient having weight loss, voracious appetite, and other symptoms will be there. So weight loss is there. You have to think of hyperthyroidism also. So best thing, next. So that is the first criteria. If you check a random blood sugar, if it is more than 200 with the symptoms, that is enough for a diagnosis of diabetes. Then next day you can ask them to come for a fasting and postprandial blood sugar and also a HbA1c. So normal glucose tolerance. So fasting blood sugar less than 100 is the normal. 100 to 125 is impaired glucose, fasting glucose, and if it is more than 126 milligram per deciliter, it is a definite of diabetes. Symptoms diabetes, random blood sugar, I already told you, more than 200. That is suggestive of diabetes. So then HbA1c, expected HbA1c is less than 5.6, 5.7 to 6.4 is a impaired pre-diabetic stage. So WHO now removed the term pre-diabetes. So impaired glucose tolerance. Then if the HbA1c is more than 6.5, it is definite for diabetes. So 2 hour postprandial glucose 140 milligram and also is less than expected less than 140, 140 to 149 is a impaired glucose intolerance. Then more than 300, definitely it is a diabetic. So these things you should, HbA1c, so random blood sugar, your students, you must know this one. So anybody, if maybe a neighbor, if you are doing medicine, they will come and ask you, so whether it is a diabetes, whether should take medicines or not, right? So you should be able to guide them to do what are the things you can do. And another thing, regular checkup, they have to do follow with every month, at least every month, with a fasting blood sugar and postprandial blood sugar, or even a random blood sugar. And once in 3 months, they have to do a HbA1c for preventing the complications of diabetes. So next. So next is same thing. So next is given gestational diabetes, that will be dealt by with Madam. So with this talk, I am finishing the classification and the diagnosis of diabetes mellitus.
Any questions from the audience? Thank you for the informative session, sir. I kindly request Dr. Basil Joseph. Resident Medical Officer, KMMC, to honor the speaker. Now it's time for questions to the students. What is MODY? MODY. Please raise the hands. Fasting blood glucose criteria for diagnosing diabetes mellitus. Please raise a hand. Age of initiation. Which is the commonest type of diabetes and the percentage of people affected by the commonest type? Please raise your hand. Age of initiation of treatment in diabetes mellitus, diagnosing diabetes mellitus. Screening. Please raise your hand.
25, come.
Due to time constraints, we kindly request the speakers to stick on to the designated time limit. Thank you. We know that gestational diabetes mellitus is a condition that can impact both the health of the mother and the baby during pregnancy. Today, we will have the opportunity to gain valuable information from Dr. Aradhi Kannan, consultant physician and diabetologist, Sundaram Arulraj Hospitals, Thuthukudi.
So, respected leaders of the profession, professors, co-speakers, and dear students, a very warm good morning to all. At the outset, first I would like to take this opportunity to thank Professor Dr. Prince Pius sir for giving me this opportunity to speak on gestational diabetes mellitus to this learned gathering today. Thank you, sir, for organizing this event on behalf of RSSDA Tamil Nadu chapter, as I represent the Executive Committee of Tamil Nadu RSSDA Tamil Nadu chapter as a co-opted member. Gestational diabetes, as we know, is indeed a very broad term, and it is becoming a pandemic today. So it is very popularly known as the mother of NCDs. Next. So this is the framework through which I will be taking you all through my talk today. Next. Going on to the prevalence of GDM, in India it varies from 3.8% to 21% in different parts of the country, and is found to be more prevalent in the urban areas than the rural areas, done by Mohan sir and team from Chennai. And GDM has found to be happening in about 6 of every 100 pregnancies. And the incidence of GDM has increased 8 times for pregnant women greater than 35 years of age than women less than 25 years. And Indian women have 11-fold increased risk of developing glucose intolerance during pregnancy. And a significant proportion of live births, as you can see here, are affected by hyperglycemia in pregnancy, with 80% due to GDM, a global prevalence of 14% and 11% in Asia. Next. So this is an umbrella term, the new nomenclature which has been brought out. We have, when we take gestational diabetes, we have a term pre-gestational diabetes, which comprises of type 1, type 2 and all the other types of diabetes, which Professor Christopher sir has explained excellently for the past 20 minutes to us. And then comes the hyperglycemia in pregnancy. It is divided into 2, that is diabetes in pregnancy or overt diabetes diagnosed during pregnancy. And the other one is a GDM, either whether it is the early GDM or the standard GDM, which we find out at 24 to 32 weeks. Next. So GDM is any degree of glucose intolerance with the onset of first recognition during pregnancy. And David Barker, he was the scientist who conceptualized this term as early as in 1938 itself, that the susceptibility to lifestyle diseases was programmed intrauterine. And the major focus for us will be on GDM as a future marker for the risk of developing non-communicable diseases, both in the mother as well as the offspring. So, and our guru, Professor Dr. Sesha, says, gestational programming, he calls it a gestational programming, which is a process whereby various stimuli, like whether it's the maternal fevers or the stresses of the mother that occur at the critical or sensitive periods of the fetal development, permanently causes changes in the structure, physiology, metabolism, which predispose individuals to disease in the adult life. Next. So going on a little of the basics, glucose is an uninterrupted nutrient supply to the fetus, and the metabolic goals of our pregnancy will be in early pregnancy to develop anabolic stores to meet the metabolic demands in the late pregnancy, and in late pregnancy to provide fuels for fetal growth and energy needs. Next. So the physiological changes which take place in a woman's when she is pregnant is during pregnancy, there is a state called the diapetogenic state, which peaks at 28 to 32 weeks. It is mainly due to the hormones produced by the placenta, that is the human placental lactogens, the cortisols, which all cause a state of insulin resistance. And as glucose crosses via the bloodstream from the mother to the fetus, both the blood sugar levels will be somewhat equal. Next. So in the first trimester, because of the increased insulin sensitivity, there is a tendency towards more of hypoglycemia. And as she progresses into the second and third trimester, there will be more of the form of insulin resistance, which I told you. So glucose tends to build up in the blood instead of being absorbed by the cells that make insulin less sensitive, effective, hence the hyperglycemia. And once she delivers, the symptoms will all disappear. But the baby, there are chances the baby can develop hypos because the woman's sugar travels to the placenta to the baby. Next. So the glycemic targets during pregnancy, which they say are fasting should be less than 95, the 2-hour postprandial less than 120, and the A1C targets will be the 6 to 7%. And now we have the time in range, which is another new term, which says that in 24 hours, 70% of the day, you should be within that range given for the DDM mothers, whether it's type 1 diabetic, type 2 diabetic patients, or gestational diabetic patients, so that we can achieve and prevent the reduction of development of macrosomias, neonatal hypoglycemias in pregnancy, complicated by type 1 or even type 2 also. Next. So what is this overt diabetes? This is in pregnancy when you get a fasting blood glucose of grade 1 126 or an A1C of grade 1 6.5. Other complications like diabetic retinopathy is already present, or casual blood glucose or after 75 gram OGTT you get a blood sugar of grade 1 200. You can say the patient has already had diabetes. So we call it as overt diabetic. Going on the risk factors. If the mother already had a history of having given birth to previous macrosomic babies, the race of the patient, PCODs, essential hypertension patient, history of spontaneous abortions, unexplained stillbirths, family history of diabetes, patient is obese, and age older than 25 years are the common risk factors. Going on to the maternal complications. So the complications which can occur during pregnancies, diabetic ketoacidosis, the deterioration of complications like retinopathy and nephropathy, and hypos due to the insulin usage. And during pregnancy, obstetric complications which can occur are spontaneous abortions, premature births, polyhydramnias, pregnancy-induced hypertensions, and maternal distress. And what can occur during labor? There can be prolonged labor, shoulder dystocias, perineal injuries, postpartum hemorrhages, and forceps deliveries. And in puerperium, puerperal sepsis can occur, and failed lactation can be there. Going on to the fetal complications, during the antenatal period, we can have fetal distress or fetal death can occur. Congenital malformations, various cardiac abnormalities can occur, macrosomic babies, delayed fetal developments, central nervous system, you can have spina bifida hydrocephalus, skeletal changes like cleft lip, cleft palate can occur, and you can have ureteric duplications, situs inversus, renal agenesis, etc. And during birth, there can be birth injury due to shoulder dystocia. Next. And neonatal complications can be hypoglycemias, respiratory distress, hypocalcemia, hyperbilirubinemia, and cardiomyopathy. And more of IUDs are common in our GDM patients, mainly because of uncontrolled diabetes. It causes maternal hyperglycemia. This leads on to fetal hyperinsulinemia, which leads the baby to develop fetal hypoglycemia, hence hypoxia. And the hyperinsulinemia is mainly because of the increased oxygen demand of the fetus, and the HbA1c binds more of oxygen but releases less oxygen, hence fetal hypoxia. And because of the overt diabetes, already the patient will have vasculopathy, so fetal growth regression will occur. Next. So whom are we going to screen? We need to screen all women who come when they are pregnant. At any time, you may need to screen them. There is universal screening is a term which is used for that, as Indian women have 11-fold risk of developing glucose intolerance during pregnancy compared to other Caucasian women. Next. So how are we going to screen? We are going to use the universal DIPSI criteria, that is the Diabetes in Pregnancy Study Group of India. This is accepted by the Government of India also since 14 March 2017. All women have to be screened at 24 to 28 weeks with of gestation with 2 hours of 75 grams of after oral glucose. It's a one-step approach. And why do we do it actually? To identify and treat our patients, and also to prevent the development of diabetes in our future generations. Next. So it's a single step test. There is no need to keep the patient fasting. You give the patient 75 grams of glucose in 300 ml of water, and after 2 hours, you see their blood glucose levels. If the patient had vomiting in between, please repeat the test. And when you see the blood sugar levels, if it is more than 120, you can come to a diagnosis that patient has a gestational diabetes. It is very simple, economical, and acceptable. Next. So these are the various organizations around the globe, the World Health Organization, or the IDPSG, the DIPSI, American Diabetes Association, European associations, obstetrician organizations, all of them have various guidelines. But what we are following is the DIPSI guideline. It was first a two-step approach, but now we are using the one-step approach. Next. Going into little basics of the embryology of the beta cell development. So each islet cell in the pancreas of the baby functions as an endocrine organ. And the human pancreas actually begins to develop 4 weeks after conception. And the first insulin deposits can be found between 7 to 8 weeks.
and pancreatic islets differentiation occurs between 10th and the 11th week of gestation. So when we need to recognize and respond to maternal hypoglycemia starts by the infant at 11th week of gestation. Next. So it is very ideal to see that prediction of GDM in a 2-hour ppbs of greater than 110 at 10th week, we can surely say that the mother has GDM. Hence, 8th week itself, ppbs has to be estimated. So any time the mother comes to you, please ask her, do the ppbs. There is no time limit that till 24 weeks we need to wait. Because if we are able to get it at the 8th week, the ppbs is greater than 110. We have a grace period of 2 weeks in order to get a ppbs of less than 110. After which what will happen, the baby, after that the patient actually, after 11th week, the sugars will become normal. Because the fetus will start developing, the insulin secretion will occur. So fetal hyperinsulinemia will go. So we will think we have brought the patient under control. It's not like that. It's actually affecting the baby. Next. So going on to the management, first is we need to have a preconceptual care, tight glycemic controls, monitor the patient and the fetus, labor management, multidisciplinary approach is very, very important, and postpartum care and follow-up of the future. Next. So preconception care, we should plan all pregnancies. All women, why are we here today to speak to younger generations? We need to plan pregnancies, look after the health of the woman who is going to get pregnant. Before we need to see whether her weight is okay, whether she has thyroid, she has any anemia, any other comorbidities, PCOS, anything she has. It has to be controlled. She has to go in for a weight loss. Only then you ask her to get pregnant, so that we do not transfer the genes to our children. And we need to educate them also about the importance of this pre-pregnancy planning. And also do all the general assessments of all metabolic statuses, screen for complications, and review all the, she's on any concomitant medications, review them also. Start the women on 400 microgram per day of folic acid, starting at pre-consumption, and continue it till 12 weeks of pregnancy to avoid neural tube defects. And lifestyle assessment should be done throughout the pregnancy also. Next. And going on to the medical nutrition therapy, you need to give her a well-balanced diet. Only a weight gain which is needed should be done. We need to prevent the development of overt diabetes and postprandial hyperglycemia. And even after 2 weeks, with only medical nutrition therapy, we are not able to control her. We need to switch to drugs. So in GDM, we give them, depending on the weight, in a normal weight woman, we can give her 30 kilocalories per kg per day. If she is overweight, you give 24 kilocalories. Morbidly obese, allow only 12 kilocalories per day. And the diet should have 40% carbohydrate, 30% protein, and 30% fat. You give them as a break of 3 meals and 3 snacks, with breakfast 10%, lunch 30%, and dinner 30%, and snacks totally will be only 30% of their diet in 24 hours. Next. Regarding the BMI, which I have told you, underweight, if the patient is underweight, she can gain during her pregnancy, she can gain about 12 to 18 kgs. If she's on the correct ideal body weight, let it be within the 15 kgs. She's overweight, allow only 7 to 11 kg. She's morbidly obese, allow only up to 9 kg increase in her weight. Next. So, first you try a pregnant woman with GDM, try a medical nutrition therapy for 2 weeks, still her 2-hour postprandial is under control. Continue medical nutrition therapy. If it is greater than 120, start insulin therapy. So, and if it is less than 120, you monitor 2-hour pppg up to 28 weeks. Once in 2 weeks, we need to see the postprandial. After 28 weeks, do it once a week. And after starting insulin, what happens if the sugar is greater than 120? Monitor the fasting and 2-hour postprandial every 3rd day. And with that, we need to adjust our insulins. That I will tell you in the insulin part. Next. So antepartum care, insulin is the drug which is accepted universally, but today we have a lot of literature which says we can take in metformin also. Now, other than the regular insulins, we have the insulin analogs today, Glargine, Detimer have all been approved, Aspart and Lispro also. Insulin dose has to be individualized. You start with 0.7 units per kg, you calculate, give 2/3 of the insulin in the morning dose and 1/3 in the evening dose. Next. So here I've given you the types according to the action, onset, peak, duration, and the dosage at which you should give, so that we get a 24-hour glycemic control. Next. And during the first 10 weeks, you need to screen her for complications because she would not have come for preconceptual counseling. So if she had come to the first time, please screen for all complications. Always A1C should be less than 6. Fasting within 90. 2-hour ppbs less than 110. That is what should be there. Next. And also you can give her an ultrasound monitoring, all this as per her physician follow-up. Please let them do it. And also look into it at 12 to 16 weeks, whether the patient has been started on aspirin from you can use from 100 to 150 mg per day so that we can prevent the risk of developing preeclampsia. Next. And as I already told you, metformin and glyburide was too commonly prescribed OHAs during pregnancy, but now they do not, none of the various guidelines support the usage of sulfonylurea, but metformin is being used in the early weeks. It has been found to be beneficial to control the blood sugars. Next. Here I have. So if you have a 2-hour ppbs of greater than 120, so you're going to give the patient on a premix insulin 30/70. So you give the subcutaneous insulin 30 minutes before breakfast once a day, and you calculate the insulin, as I've told you, it's 0.7 units. So if the sugar you have between 120 to 160, start with 4 units. 160 to 200, start with 6 units. More than 200, you start with 8 units. And keep monitoring the patient. And if the patient, after 3 days, fasting is less than 95 and 2-hour ppb is less than 120, continue the same dose of insulin with medical nutrition therapy and mild physical activity. Next. And what happens if you keep repeating it every 3rd day, the insulin has to be adjusted. But if it does not come down, you see here you have both under control, you are still continuing. But here is in the second part, as you can see, fasting plasma glucose less than 95. The 2 hours is greater than 120. So you keep repeating again, keep adding the doses according to the blood sugars I've told you, 2 units, you keep increasing. If it is ppbs is raised, you add 2 units pre-breakfast. If the fasting is increased, you add 2 units pre-dinner. Please remember this always. Next. So we need to monitor at least 4 times per day. Most of our patients won't do. At least 2 times per day should be done. And if they're able to do 4 times, ask them to do fasting and 3 times postprandially. 3 times postprandially. And if the target levels are achieved, you can do once in 2 weeks, 28 weeks. And after 32, give greater than 32 weeks, do at least once a week. And next, all the scans and the marker tests as per your physician advice, you ask them to do. But they will keep coming, ask them to come. Every time they visit their physician, they should visit their diabetologist also. Also do a fundoscopy, follow up the microalbuminuria also. Next. And intrapartum, diabetes is not an indication for preterm or cesarean delivery. So if the metabolic parameters are satisfactory and no indication of adverse fetal growth, ask them to continue till term. And you maintain the blood sugar during labor at 70 to 110. But if it is going a little down, you can give appropriate dose of regular insulin with dextrose. Next. Always prefer to deliver it in a tertiary care hospital. If the GDM is controlled on diabetes alone and no complications, you can deliver at 30 weeks, at 40 weeks. If the patient is on insulin, induction needs to be done at 38 weeks. Vaginal delivery is allowed if baby is not macroscomic. And glucose levels are checked hourly. NS can be given less than, as I told you, glucose levels are less than 70, start 5% D, glucose is greater than 40, regular insulin you can give by IV infusion. If baby weight is greater than 4 kg, cesarean section needs to be done. And if there's any other complications, please immediately deliver the baby. And if it is preterm, plan steroids with strict blood glucose monitoring. Next. So, and after the delivery, glycemic targets to non-pregnant targets you can do as per the standard recommendation, which was given by the previous speaker. And you need to reassess again at 6 to 12 weeks with an OGTT and follow up the patient. Recommend breastfeeding and also contraception and pre-conception counseling, planning of pregnancy before her next pregnancy. Next. So this I've just put it as a flow chart, as you can see. Before her hospital discharge, discuss the risk of diabetes. Encourage breastfeeding. Schedule the postpartum follow-up. Make sure she attends it. 6 to 12 weeks postpartum, assess her glucose tolerance. If the sugars are in the diabetic range, give lifestyle modification along with medications, prefer insulin sensitizing drugs. If it is only in the impaired stage, need to start lifestyle modification. Now, if it is normal, lifestyle modification, annual checkup by be done. And in the impaired ones, monitor A1Cs and fasting glucose every 3 to 6 months. If the glycemia is rising, start medication. To stable, continue the same line of management. Next. So what happens because of this diabetes? If you are not going to follow it up, what can it do? Why do you think it will affect the baby? It is mainly due to the concept of intergenerational programming. So which happens by the 11th week, this intergenerational programming has already been done. If the mother was obese, it is going to be written in the gene that it is going to be transferred to the baby. So the intrauterine environment will be associated with adverse metabolic effects in the offspring, promoting an intergenerational cycle of obesity, cardiovascular disease, and NAFLDs. Next. So what happens, as you can see here, does the weight actually matter? Yes, it matters. So when she first gets pregnant, she's very thin. She gets pregnant, she puts on weight. So there will be increased BMI, increased fat mass, and visceral fat will also increase. And after her delivery, she should lose all that weight. If she does not lose, what happens? With this excess weight, she gains extra 15 kg more. So the metabolic consequences are she can develop more chance of GDM, more chance of preeclampsia and hypercholesterolemia. And even after the second delivery, she does not, she still retains her weight. There is a risk of development of cardiovascular disease, metabolic syndrome, and type 2 diabetes. Next. And the CV risk in women with GDM, as you can see, the birth of cardiac disease, they are found as a mechanism linking GDM and early onset of cardiovascular disease in the offspring has been found as early as in 2022. That is the intergenerational perpetuation of cardiovascular disease. It causes epigenetic changes in the baby, and it is going to cause the birth of cardiac disease in the baby. Next. And also what happens because of this dysglycemia, inflammation, oxidative stress, all this causes an unhealthy intrauterine environment, leading on to the development of not only anatomical malformations, it causes hypothalamic dysfunction, obesities, delayed neurocognitive developments, neurogenerative diseases. So even our CNS is going to be affected in the offspring. Next. And NAFLD, women with previous GDM have a higher prevalence of fatty liver than those without GDM. So if by a simple ultrasound, if you're able to find liver fat, this you can take it as it can predict gestational dysglycemia. So we are advising weight loss is very important. And also serum levels of increased GGT can itself predict the risk of GDM in subsequent pregnancies. Next. Going on to malignancies, there are increased chance of malignancies nowadays by various researchers. They say ovarian, endometrial, breast cancer, and pancreatic cancer related risks are very high in GDM mothers. Next. And ophthalmic complications, they can develop diabetic retinopathy, retinal detachment, and glaucomas. Renal complications like hypertensive renal diseases without renal failure, with renal failure, chronic renal failures, and end-stage renal diseases. Next. So this GDM is a window of opportunity. It is a vicious cycle of diabetes. So women with GDM, with beta cell dysfunction, and insulin resistance leads to big infant of women with develops a GDM. The baby gets, you get a macrosomic baby, epigenetic changes have taken place in this baby, so it is more prone for obesity and diabetes in the youth. Young onset of diabetes is very, very high, leading on to obesity, PCOS, preeclampsias. Further risk, when she gets pregnant, this is going to still continue as a vicious cycle. Next. So the take-home message from my talk will be a good control of diabetes during pregnancy can improve the intrauterine environment and reduce the risk of complications in the offspring. Pre-pregnancy planning is ideal for a better fetal outcome, and it is very, very necessary to optimize the metabolic control early in pregnancy. For prevention of GDM, PPBS greater than 110 at 10th week is a crucial time during pregnancy, and prediction of GDM and primordial prevention should be our goal. So long-term follow-up of the mother and baby is very, very essential. And as Sesha says always, diabetes-free generation. We need to focus on the fetus for the future. So every baby deserves a healthy mother for the long term. So let's all try to reduce this intergenerational transfer. Next. So thank you very much. The womb is more important than the home. Thank you. And also I would like to take this opportunity to invite you all for our National RSSDA Research Retreat Conference 2025, which is taking place in Madurai in March 1st, 1 and 2. It's a national conference where what is research, how much more you can do in research, and they give a lot of grants. RSSDA is a main platform for research only. It's a very big opportunity for students, so please take part in it. And next. And I also take this opportunity to invite you for our Tamil Nadu chapter. RSSDA conference is taking place in Coimbatore, August 9 and 10. We request you all to participate in it. Thank you very much for the opportunity.
Any questions from the audience?
Thank you, madam. Infertility specialists, many of us put our, even normal glycemic, especially in obese PCOS, we put our patients on preconceptionally, even when they come for the infertility treatment, we put them on metformin. So usually we continue it during pregnancy also. But their sugars are always normal. So I would like to know your views on that, ma'am.
That's a very question, ma'am. We should continue on metformin. There's no alternate thinking on that. And this metformin, even if the sugars are normal, this metformin is not going to mainly cause any hypos. And it is not going to cause any other, like what do you say, any complication because of metformin. So what we are trying to do is reduce the dysglycemia, which has occurred already. So the patient is already a diabetic, or the patient is a PCOS, for that you have given. So it is not going to bring it to down the level. Anyway, she will be taking
most of them, even because now we have recently started a research in lean PCOS.
Yeah.
So
Lean PCOS, you're giving it at 250, ma'am. 250 or 500?
Right now, we have not put out any of our, we are just monitoring them.
Okay.
What is it, the thing? Because
So
lean
they are in
PCOS
control with only weight loss? No.
in fact, they are very skinny.
Okay.
So they are well within the BMI, in fact, very less as well. So in those kind of patients, I would just like to know an input of yours that we should refrain from using metformin, is it?
There is no need to refrain from using metformin, madam. You use it at OD dose.
Okay.
Okay.
So you
at
need
low
to
dose,
say
you
at
please start the
250
patient.
usually.
Yeah.
Thank you so much.
It's going to help her a lot.
Thank you so much.
Thank you, ma'am. Thank you for the insightful presentation, ma'am. I kindly request Professor Dr. Pavadarani, Professor of Physiology, to honor the speaker. Questions to this audience. When is the peak diabetogenic state in pregnancy? Please raise your hand. Please raise your hands. Please come forward. Come forward.
Hello. 28 to 32 weeks.
Target postprandial glucose level in pregnancy? Please raise your hand. Please come. Mike.
At 10th week, 8 to 10 weeks.
Range.
Yes.
Please.
Less than 40%.
pleased to have Dr. Talagar, Professor of Medicine, Sri Mogambiga Institute of Medical Science, Kulasegaram with us today to discuss the acute complications of type 2 diabetes mellitus.
Respected Reverend Father, Pro Chancellor, Dean, and Administrative Officer, other senior faculties of the Muttom Medical College, and my dear students. Good morning to everybody. Actually, the topic given to me is acute complication of diabetes mellitus. It happens to be very last that too. Allotted time is only just 30 minutes. So I just changed the topic to metabolic complications of diabetes mellitus. Now, you're just talking as a OP. Now I have to take all you people to the intensive medical care unit. There only we manage these complications, right? How far I am going to impress you by this presentation is going to be boring. Anyhow, when you come to final year, it will be asked as a question, theory question. And in practice also, is going to be very useful, right? Anyhow, next slide. As already discussed extensively, it's a chronic disease that occurs when the does not produce enough insulin, or when the body cannot effectively use the insulin it produces. These are some statistics, so many statistics available. The most important is India is going to be the diabetic capital of the world. Why we are mentioning this? You should know the magnitude of the problem. All you people, budding doctors are going to practice medicine here, and we need more diabetologists, physicians, and endocrinologists to manage this. 50% people are unaware of the diabetes status, which leads to health complications. Human burden on the health sector. Next slide. Most important thing is the diabetic ketoacidosis, non-ketotic hyperosmolar, hyperglycemia, hyperosmolar coma, then hypoglycemia and hypoglycemic coma. And most of the things are mainly the most important etiological factors is infection. Next slide. What is diabetic ketoacidosis? You see the three things, ketosis, hyperglycemia, all these things, is defined the presence of all three things. There is hyperglycemia, usually the glucose will be more than 250, ketosis should be there, and acidemia. The metabolic acidosis, the pH should be less than 7.3. Next. What is the role of insulin? Required for transfer of glucose into muscle, adipose tissue, and liver, and it is liposis. You can see the slide. The absence of insulin leads to what happens? Glucose accumulates in the blood, use amino acids for gluconeogenesis, converts fatty acids to ketone bodies, there is acetone, acetoacetate, and beta hydroxy butyrate. This is the thing that will have the metabolic effect happens to the body because of insulin deficiency. What happens? There is hyperglycemia on one sector, then it will lead to hyperosmolality, that will lead to dehydration, that will lead to renal shutdown and shock. And some of the patients will go from hyperglucosuria, electrolyte losses. Again, because of insulin deficiency, there will be lipolysis, increased free fatty acids, ketones, acidosis, and cardiovascular collapse. Next slide. Come to the pathophysiology of diabetic ketoacidosis, unchecked gluconeogenesis, that will lead to hyperglycemia. Osmotic diuresis, that will lead to dehydration. Unchecked ketogenesis, that will lead to ketosis. Dissociation of ketone bodies into hydrogen and anions, that will lead to anion metabolic acidosis. Often, these things are precipitated by an event like infection, as I told you earlier, lack of insulin administration. Next slide. If you come to the clinical picture, most of the patients, as I told you earlier, most of the diabetes asymptomatic. They present the first incident itself with these features. with a history of thirst, polyuria, abdominal mild, diffuse abdominal pain, nausea, vomiting, or profound weakness. You go for the physical examination, there will be kusmal aspiration, then fruity odor, there is tachycardia, dry mucous membranes, poor skin turgor, and abdominal diffuse tenderness. Next. Coming to the precipitating events, it may usually the most common thing is infection. It may be gastroenteritis, sepsis, something, and inadequate insulin administration. Infarction may be a cerebral, coronary, mesenteric, or peripheral, or it may be a drug abuse due to cocaine, or it may be pregnancy. Next. Coming to the diagnosis, we have the order for these investigations: complete blood count, serum ketones, urine ketones, and sugar. Calculate serum osmolality and anion gap. Urine analysis and urine culture, cancer blood culture, cancer chest X-ray, and even acid-base assessment. Next. Coming to the treatment, this is a big flow chart. This is hourly management of diabetic ketoacidosis. The first hour, that is 0 to 60 minutes, you have to establish the IV access, assess the patient, perform initial investigation. Very important. You just start with 0.9% sodium chloride. If the systolic BB is more than 90, give 1 liter over 60 minutes. If it is less than 90, give 500 ml over 10 to 15 minutes. Then reassess. If the BB remains still 90, you have to see an expert opinion also. Commence insulin treatment. That is 50 units human soluble insulin, 50 of 0.9. So sideways, you are supposed to start 2 IV lines. One for the insulin, one for the normal saline. Interval is 0.1 units per kg body weight per hour. When you suppose the patient already on basal insulin, you continue with it. Perform further investigations. Establish, this is very important. You draw a flow chart. That is monitoring schedule. That is hourly capillary blood sugar, ketone testing, venous bicarbonate and potassium at 1 and 2 hours. Then every 2 hourly, the first 6 hours. Plasma electrolysis every 4th hourly. Clinical monitoring of oxygen saturation, pulse, BP, respiratory rate, urine output every hour, and treat any precipitating cause. If there is infection, you treat with antibiotics. And time, 60 minutes to 6 hours. Again, you have to continue the IV infusion, 0.9. There is normal saline with potassium chloride added as indicated. 1 liter over 2 hours, 1 liter over 2 hours, another 1 liter for 4 hours, another 1 liter for 4 hours, and finally 1 liter for over 6 hours. Add 10% glucose in 125 ml per hour IV when glucose is less than 252. So you have to monitor, as I told you, every hourly. Be more cautious when the fluid replacement, especially in older generation and young people, pregnant patients, and those with comorbidities like renal problem, heart failure. You have to be very careful. If the plasma sodium is more than 155, use half normal saline. Then again, another important electrolyte is potassium. For plasma potassium, if it is more than 5.5, you not give any potassium replacement. If it is 3.5 to 5.5, you give 40 millimoles per liter. Then less than 3.5, you need more. Then from the 6 hours to 12 hours, your management is, you always monitor the clinical status, glucose, ketonemia, and acidosis, and all this should be improving. And continue food replacement, continue insulin administration, assess for complications of treatment, that's very important, fluid overload and cerebral, especially in children. Some of the patients develop cerebral edema, and the mortality is high in type 1 diabetes in children. Then from 12 to 24 hours, you have to see the ketonemia and acidosis should have resolved by that. Usually, within 24 hours, if you manage carefully, the whole thing will subside. And ketones should be less than 0.3 millimoles per liter. Bicarbonate should be more than 80 millimoles per liter. And the patient is not eating or drinking, you have to do some of them. That is, continue having insulin infusion at a lower rate, because the sugar has come down, and continue IV replacement and biochemical monitoring is also important. If ketosis has resolved and the patient is able to eat or drink, reinitiate with subcutaneous insulin. That is very important. For IV infusion also, you should be very careful. You see that the blood sugar falls with 50 milligram every hour or hourly monitoring. Suppose it falls more than that, the direct complication will occur, that is osmotic encephalopathy. That is, slowly you have to reduce the blood sugar. Otherwise, the patient prone for osmotic encephalopathy. Then there are additional procedures are there. Urinary catheterization, if you want, if the patient is anuric, even after 6 hours. Insert nasocals if the patient attended or there is persistent vomiting. You insert the central venous catheter also to monitor the fluid overload, especially for people with comorbidities. Measure ABG, kilowatt cancer, repeat chest X-ray, saturation, all this should be more than that. And you should also go for the ECG monitoring in some of the cases. And give thromboprophylaxis with low molecular weight heparin. Next slide. Again, switching over the IV line to subcutaneous, you have to give subcutaneous insulin before you taper the IV infusion. Suppose you taper it rapidly, there is every chance for rebound ketoacidosis. The patient will picture present after some time with the same picture. And for the fluids is a very critical part of treating patient decay. That is, intervention should place extravascular, intravascular fluids and electrolysis. So they also dilute both the glucose level and the levels of the circulating counterregulatory hormones. Fluid itself leads to correction of acidosis to some extent. So in most of the patient, if you are able to manage the fluids correctly, you are more than 50% you can revive the patient. Insulin needed to help switch from catabolic state to anabolic state with uptake of glucose in tissues and the reduction of gluconeogenesis, as well as free fatty acid keto production. Next slide. This is the normal schedule. That is saline and mainly hemodynamic status. First 4 hours normal saline. Consider hormonal saline after if there were serum sodium is more than 150, and change to dextrose, 5% or 10% dextrose when the glucose level reaches 250 or less than 250. This is the schedule already shown. Next. Then insulin, we always use regular insulin. That is 10 units IV status, then 0.15 units per kg IV stat. Start regular insulin infusion, 0.1 units per kg per hour or 5 units per hour. Increase insulin by 1 unit per hour every 1 to 2 hours if less than 10% decrease in glucose or no improvement in acid-base status. See, whenever we find, we suspect insulin resistance, you have to double the dose. Decrease insulin by 1 to 2 units per hour, that is 0.05 to 0.1 units per hour when glucose is less than 200, 250, or progress improvement in the clinical status with decrease in glucose more than 75 per hour. You always, as I told you, we should be cautious about preventing osmotic encephalopathy. Do not decrease insulin infusion to less than 1 unit per hour. Next. Maintain glucose, not strict control of glucose, not because it produces a U-shaped curve. Maintain glucose between 140 to 180. If blood sugar decreases to less than 80, stop insulin. Right? You wait for 1 hour, you again check it and restart infusion. If the glucose drops consistently to less than, you start on 10% dextrose to maintain the glucose at 140 to 180. Once the patient is able to eat and consider, you change it to subcutaneous insulin. Oral have short-acting insulin, subcutaneous, and continue IV infusion 1 to 2 hours. As I told you earlier, before tapering the IV infusion, you start him on subcutaneous insulin. For patients with previous insulin dose, return to prior dose of insulin. For patients with newly diagnosed diabetes, full dose of subcutaneous insulin based on 0.6 units per kg per day. Next. Then coming to potassium replacement, if the potassium level is more than 5.5 milliequivalents, do not administer potassium. Or if the patient is anuric, it all depends on the urine output. Use potassium chloride in potassium phosphate. Also, they say they want to alternate potassium chloride phosphate if there is severe phosphate depletion and patient is unable to take phosphate by mouth. And IV potassium each liter fluid administered unless contraindicated. As I do, if the patient unwilling, output is not good, you have to be careful. Serum potassium is 3.54, you just 40 equivalents per liter, 3.5 to 4.5, 20 milliequivalents per liter, 4.5 to 5.5, 10 milliequivalents. If it is more than 5.5, stop potassium infusion. Next. See, these are the guidelines recommended by the William Textbook Endocrinology. That is, serum potassium is less than 3.3 milliequivalents. Full insulin give 40 milliequivalents of potassium. That is 2/3 potassium chloride and 1/3 as potassium phosphate until you normalize the deficit. If the potassium is more than 5 or equal to 5, do not give potassium, but check potassium every 2 hours. If the serum is potassium is more than equal to 3.3 but less than 5, give 20 to 30 milliequivalents of potassium in each liter of IV fluid. 2/3 as potassium chloride and 1/3 as potassium phosphate. They keep serum potassium between at 4.5. Next. Then coming to bicarbonate, usually we don't advocate bicarbonate replacement because bicarbonate has its own side effects. Replacement and rapid reversal of acidosis can impair cardiac function, reduce tissue oxygenation, and promote hypokalemia and hypercalcemia. However, in presence of severe acidosis, if the pH is less than 6.9 and there is hemodynamic instability with pH less than 7.1 and hyperkalemia with ECC painting, you add bicarbonate therapy. Otherwise, normally we don't recommend bicarbonate. In the presence of severe acidosis, the EAD advises bicarbonate millimoles, 50 millimoles per liter of sodium chloride, 200 ml of sterile water with 10 milligrams of potassium chloride per hour for 2 hours until the pH reaches more than 7. Next. Next slide. This is the way you add bicarbonate. If the pH is less than 6.9, you give 100 millimoles of soda bicarbonate, dilute in 400 ml of water, infuses 200 ml per hour. If the pH is 6.5 to 7, you sodium bicarbonate 50 millimoles, dilute to 200 ml of water and infuses 200 ml per hour. If it is pH more than 7, you do not give bicarbonate. Repeat bicarbonate administration every 2 hours until the pH is 7. You monitor for serum potassium also. Next. Coming to the glucose administration, plasma glucose reaches 250 milligram or 300 milligram HSS, decrease the insulin infusion rate to 0.05 to 0.1 unit per kg per hour. That is 3 to 6 units per hour. If you add dextrose to the intravenous fluid or maintain the above glucose values until acidosis in decay and mental appendation and hyperosmolarity in HS are resolved. You have to monitor the patient very carefully. Next. What are the criteria for resolution of when you stop the treatment? This glucose less than 200 milligram. Serum bicarbonate should be more than 18 milligram or equal to or more than milliequivalents. And pH should be more than 7.3. When the decay is resolved and if the patient is in continuing intravenous insulin and fluid replacement and supplement subcutaneous regular insulin as needed every 4th hour, if needed 4th hourly. Next. Then coming to the next important acute complication, that is hyperglycemic hyperosmolar state is a syndrome characterized by impaired consciousness, sometimes accompanied by seizures, extreme neurologic deficit, extreme dehydration, and extreme hyperglycemia. There is not accompanied by ketoacidosis. At times, minimal ketosis may be present. Usually, it won't be associated with ketoacidosis. Next. These are the pictures. This is the difference between diabetic ketosis and HS state. Ketonemia or ketone will be present in the case of ketoacidosis, where ketone is usually absent. Serum osmolarity will be normal, whereas in HS serum osmolarity more than 320 milliosmoles. Then pH will be less than 7.3. There the pH will be more than 7.3. And serum glucose more than 250 milligram by deciliter, whereas serum glucose will be more than 600 milligram severe glucose level. Then physical examination, usually they present severe dehydration, various neural deficit, coma, transient hemiparalysis, hyperreflexia, effervescence, or seizures, altered states of consciousness from lethargy to coma are observed. Findings also the co-estimatic problems are very important. That is, renal disease, cardiac disease may be evident. Next. The laboratory findings, extreme hyperglycemia, that is, blood glucose less more than 30 millimoles per liter on overall common. A markedly elevated serum osmolality, that's important. Normal 290 here will be more than 350. Serum ketones are usually not detectable, patient not acidic. Serum sodium may be high if severe dehydration of present, normal or high depending on serum. Then serum potassium levels may be high or low or normal depending on the osmolality. Secondary is hyperosmolality. Next. Treatment, again, is another medical emergency. The patient should be placed in intensive care unit. Most of the management is almost similar to the DKA as applicable. The goals of therapy should be rehydration, reduction of hyperglycemia, electrolyte replacement, and investigation for the precipitating factors and treatment of complications. Next. This is another chart. Again, this is hourly management. First ever, you start with the ramosaline, you start with the insulin infusion. Their point one here is 0.05 unit per kg per hour, and all clinical assessment should be done. Good score, all the establish the monitoring. That is also important. Generally, hourly glucose, calculate osmolality for the first 6 hours. Insert catheter for assessment of output chart, urine output chart. Calculate fluid balance. You start him on low molecular weight heparin as a prophylactic dose and consider antibiotic if sepsis is suspected. Next, 1 hour to 6 hours management, continue the sodium chloride infusion, then continue the insulin infusion, and you calculate the osmolality hourly and aim for gradual decline. That is very important. If the blood glucose is falling at less than 5 mg per liter, check fluid balance. If adequate, commence low dose IV insulin. Continue that. Maintain potassium, that is in the reference range, that is 3.6 to 5. Avoid hyperglycemia, that is very important. Aim to keep blood glucose at 180 to 270. This is in the first 24 hours. If the blood glucose falls below 250, commence on dextrose, 5% or 10% dextrose, and always monitor the fluid balance. Then 6 to 12 hours, again monitor the clinical and biochemical. Clinical is also very important. Don't depend too much on biochemical parameters. Continue IV fluid replacement. Continue with the treatment of underlying patient, that is antibiotics. Avoid hypoglycemia. From 12 to 24 hours, the same thing to be continued. Continue IV insulin, fluid replacement, and you have to monitor the complications also. Continue treatment for patient, avoid hypoglycemia. This is very important. For DKA, just 24 hours management, most of them, 90% will recover. Whereas in hyperglycemic, it will take minimum 2 to 3 days. For 24 to 3 days, again you have to monitor the same patient, you can convert it to support. If there is clinical and biochemical improvement, you convert it to supportive insulin regimen. Assess for signs of fluid overload, this is important. Encourage early mobilization, carry out daily food checks, and continue with low molecular heparin and ensure review by the experts. Next slide. Then one more ketose, that is the rest is euglycemic diabetic ketoacidosis. This is an uncommon diabetic complication associated with several risk factors like fasting, surgery, pregnancy, now the use of sodium SGLT inhibitors and atypical antipsychotics, some of the anti-cancer drugs. Imbalance between insulin and counter-regulated hormones with an elevated glucagon-insulin ratio. Next. Mechanism secondary to carbohydrate deficit result in generalized decrease serum insulin and excess counter-regulatory hormones like glucagon, epinephrine, and cortisol. The increased glucagon-insulin ratio leads to increased lipolysis and increased free fatty acids and ketoacidosis. Next. How will you diagnose? That is, usually there will be normoglycemia. The blood sugar will be less than 250. The presence of metabolic acidosis. The pH should be less than 7.3. And the total degrees serum bicarbonate level should be less than 18 milliequivalents per liter. Serum and urine ketones must be elevated to make the diagnosis of euglycemic diabetic ketoacidosis. Next. Management should be directed to the fluid resuscitation. The same thing, being with the administration of isotonic and ring lactase solution. Insulin infusion should follow fluid replacement, starting at a rate of 0.05 to 0.1 units per kg per hour. In contrast, diabetic management here, serum glucose is less than 250. So, dextrose 5% should be initially added to the fluids to avoid hyperglycemia. There we use only normal saline. You can use here 5% dextrose because the blood sugar is almost normal. Potassium bicarbonate replace also needed depending on the laboratory value. Next. Then another important complication is hypoglycemia. This is the most commonly caused by insulin and insulin-producing drugs used to treat diabetes mellitus, or by exposure to other drugs including alcohol. This is the Whipple's diet. There is symptoms consistent with hypoglycemia, low plasma glucose concentration measured with the precise method, relief of symptoms after the plasma glucose is raised. Next. Precipitating factors, irregular ingestion of fluid, food, extreme activity, alcohol ingestion, drug interaction, liver or renal associated comorbidities, hypopituitarism and adrenal insufficiency. Next. Coming to the pathophysiology hypoglycemia, if the sugar is 83%, usually what happens, there will be inhibition of endogenous insulin secretion. And when the value is 68, it becomes the regulatory hormone release glucagon and adrenaline. If it is 58 to 50 milligram deciliter, then symptoms of autonomic symptoms and neuroglycopenic symptoms will be appear. If it is 54 to 43, neurophysiological dysfunction and evoked response. 54, you get widespread EEG changes will be there. If it is 50, cognitive dysfunction, inability to perform complex movements. Then if it is less than 27, reduced level of consciousness, convulsions and coma. This is the pathophysiology hyperglycemia. There are so many other causes, rare causes, drugs, critical illness, hormone deficiency, then endogenous hyperinsulinism. These are seemingly well individual. Function beta cell disorders, insulin autoimmune hypoglycemia. These are rare disorders. Disorders of gluconeogenesis and fatty acid oxidation, exercise, accidental substitution, malicious hypoglycemia. Next. When coming to physical examination, the skin is cold and moist. Hyperreflexia can be elicited. Hypoglycemia is commonly as abnormality, low body temperature, and patient may be usually unconscious. There are 3 levels. Level 1, glucose is less than 70 milligram and equal to up to 54. If it is level 2, glucose less than 54. And level 3 is a severe event characterized by altered mental and physical status requiring assistance for treatment of hypoglycemia. Next. Treatment, level 1, avoiding critical starts, driving, ingesting carbohydrates, adjusting the treatment regimen. This is important. Then level 2, hypoglycemia, insulin or insulin incompatible with alpha inhibitor, only pure glucose. Glucose tablets should be used. Quick source of sugar, there are so many sources. You have to use one of the sources. Next. Level 3, here, IV 75 to 100 ml, 20% dextrose over 15 minutes, or 150 to 200 ml, 10% dextrose over 15 minutes. This is given. For glucagon intranasal 3 milligram, stable liquid glucagon or glucagon can be administered using a pre-filled syringe or auto-injector pen or syringe kit. Reconstituted glucagon lyophilase powder requires reconstitution. Usually it will be available as the lyophilase powder, and it needs reconstitution and given as a subcutaneous or IM 1 milligram. The third most important that is available everywhere is steroid. You can give any prepared steroid to treat hyperglycemia. Next. Thank you very much for your patient care.
Thank you, sir. Any questions from the audience? Thank you, sir. We are so grateful for your willingness to show your expertise with us. I kindly request Professor Dr. Kingsley, Resident Medical Officer, Professor of ENT, to honor the speaker. So let's move on to questions to the students. Which fluid is given? Please raise your hand, okay? Which fluid is given first in the management of DKA? Which fluid? Please raise your hand. Which IV fluid is given in the management of DKA first? What range of glucose levels to be maintained in DKA? What range of glucose levels to be maintained in DKA?
Less than 250 mg per deciliter. Less than 250. 200 sir. Sir, less than 200.
We are excited to have Dr. Joel Franklin, consultant endocrinologist Nagarkoil, with us to talk about the chronic complications of type 2 diabetes mellitus.
Good morning, everyone. Before I start, I would like to thank Prince Pius sir for giving me this wonderful opportunity. So the topic of today's topic for my discussion is on chronic complications of type 2 diabetes. This is a pretty huge topic. Each one can go for a 1 hour talk. So I have made sure that I will discuss just basic concepts alone. So this is my agenda. I'll be discussing macrovascular complications, diabetic nephropathy, neuropathy, and retinopathy. Next. So diabetes, as you all know, is a global pandemic, and around 537 million people are living with diabetes, and around 3 in 4 adults with diabetes live in low and middle income countries. And this is from the 2021 data, and in India, around 75 million people are living with diabetes, and it is expected to go to around 125 million in 2045. Next. So diabetes, it's basically a vascular disease. And this is the macrovascular complications include a coronary artery disease, cerebrovascular disease, peripheral arterial disease, and the microvascular complications include retinopathy, nephropathy, and neuropathy. So moving on to macrovascular complications, we all think that when it comes to complications, we do think that if there is a prolonged uncontrolled diabetes, then only all the complications will set in. That is partly true, but when it comes to macrovascular complications, they actually set in early. So for that, we should know something called as a common soil hypothesis. So what is this hypothesis? It states that the dysglycemia and macrovascular complications spring from the same soil, which is the insulin resistance. That's why even if the individual is having pre-diabetes, they will have higher risk for macrovascular complications like coronary artery disease and cerebrovascular disease. That is, once the HbA1c is more than 5.7%, around 1/10 of the people are at risk for developing coronary artery disease, and the prevalence of vascular complications in prediabetes is similar to those that with the newly diagnosed diabetes. And also the prevalence of vascular complications is about half of those with known diabetes mellitus. So when you are thinking about this macrovascular complications, if you think that if I look into the glucocentric etiology alone, I will manage the glycemic control, then everything is done, then that is completely wrong. The diabetes mellitus is just one of the main contributing factor to cardiovascular disease. There are so many other factors like high blood pressure, obesity, dyslipidemia, ethnicity. Unfortunately, we Indians are more risk for we are at more risk for developing cardiovascular disease and cerebrovascular disease. So then moving on to this glucose paradox. So as I said earlier, if we treat if we bring the glycemic control, that is, if we reach the target of HbA1c less than 7%, then that is alone not enough. We have to address the obesity part, hypertension, and dyslipidemia also, because all these factors can promote thrombogenesis. So coming to prevention of macrovascular complications, so early glycemic control, definitely lifestyle changes, and the pharmacological interventions for dyslipidemia, hypertension, and obesity. And so the ASCVD risk factors and diabetes, the risk factors and diabetes are synergistic rather than additive, and aggressive targeting of multiple risk factors reduces risk and improves outcomes. Achieving targets for blood pressure and LDL cholesterol in addition to glycemic control, lifestyle modification, and stopping smoking is essential, but only 23% of patients with diabetes met targets for glycemic control, hypertension, and lowering LDL while also avoiding smoking. So, so these are the factors which we need to address: glycemic part, blood pressure, lipid, and the agents with cardiovascular and renal benefits. And in one Swedish study, that is for a 20-year follow-up, Swedish cohort showed A1C and systolic blood pressure most significant for atherosclerotic cardiovascular outcomes. So for hypertension management, when the blood pressure goes beyond 120/80, we should start advising the patient for lifestyle intervention, DASH diet, reducing sodium, increasing potassium, and moderation. Actually, I wouldn't say moderation. You have to stop alcohol intake. Any ml of alcohol is injurious, and increasing physical activity, and reduce sodium intake to less than 2,300 mg per day, and increase the fruits, vegetables, low fat and high protein diet, and physical activity. This is most important. At least 150 to 200 minutes of moderate intensity activity should be done by the patient. Next. So, so how the target BP should be less than 130/80. So how did they come to this target? So various landmark studies have been done. The first is the Acute BP trial, where they had a very strict BP control of less than 120 systolic, but they found out that there was no significant difference in the primary endpoint with the cardiovascular death, myocardial infarction, and stroke. But they had a decrease in stroke of 41% with a side effect of increase in creatinine values. Then the advanced BP trial, where they had a fixed dose perindopril with indapamide, where they achieved a target of around 135 to 75, and the outcome was they achieved a decrease in primary endpoint and decreased all-cause mortality and CV risk. And then the STEP trial, and here they had a target BP of systolic less than 130, and they achieved a 26% decrease in primary endpoint, decrease in MI, stroke, everything. Next. So finally, like currently the BP target which has been set is less than 130/80. So how to start? So if the BP is more than 130/80 but it is less than 150/90, you can start with one agent. And if the patient is having albuminuria, it's better to go with ACE inhibitors or ARBs. Or if there is no albuminuria, you can go with ACE or CCB or diuretics. And if the BP is more than 150/90, you have to start with two agents. Start with ACE or CCB or diuretic. And again, if there is no albuminuria, then any one of the three. So this is the lipid guidelines. I haven't quoted ADA. We have a different thing. So this is the risk factor. So once a patient moves into your clinic, these are the things which you should be aware of. The major ASCVD risk factors. If the age more than 45 in males, more than 55 in females, current cigarette using, high blood pressure, low LDL. These 4 are the major ASCVD risk factors. And the other high-risk risk factors include a family history of premature atherosclerotic cardiovascular disease, CKD stage 3, B or 4, apolipoprotein B more than 130, lipoprotein A more than 150, and metabolic syndrome or mast cell. There is a non-alcoholic fatty liver disease with grade 2 or 3 fibrosis. So first we have to ask these things. If they are, then we have to subcategorize into low risk, moderate risk, high risk, very high risk, and extreme risk. Next. So then, based on the risk, then you have to set the target. Low risk, you have to, it is less than 100. Moderate risk, it is less than 100. I would say from starting from moderate risk, you better go with less than 70 because we are at a higher risk. And high risk group less than 70, very high risk less than 50. And apart from that, extreme high risk also less than 50. And another one thing is this ApoB, that is if the patient is affordable, you can opt for this ApoB. It is a conglomeration of all the atherogenic lipoproteins. It is more specific than LDL. So the combination therapy, if you are not able to achieve with atorvastatin or rosuvastatin, then you can supplement the patient with ezetimibe or the PCSK9 inhibitors. So ezetimibe is comparatively cost effective. So you can, this is from the Improve IT trial where ezetimibe was combined with simvastatin, and it showed a 14% decrease in major adverse cardiovascular events, and again 4-year and ODC outcomes which was done on evolocumab and alirocumab. So this is the anti-diabetic drugs which has proven cardiac benefits and also renal benefits, GLP-1 analogs and SGLT2 inhibitors. I'm not going to the depth of it because next speaker will be speaking about it. So moving on to microvascular complications. So here it is purely hyperglycemia specific. You control the glycemic part, then at least 60% you are doing, the patient will feel better. So this is a landmark trial which was done in India, and when they analyzed, they found out that at 1 year, microvascular complications were significantly higher in non-metropolitan cities than metropolitan cities. Of course, this was done in North India, and neuropathy was the most common microvascular complication in both the groups. So what are the predictors of microvascular complications? Duration of diabetes mellitus, degree of glycemic control, increasing age, comorbid hypertension, and genetic predisposition. The diabetic retinopathy is the most specific vascular complication. It is strongly related to the duration of diabetes and level of glycemic control. Most common cause of blindness among adults aged 20 to 74 years, and glaucoma, cataracts, and other disorders of eye occur earlier and more frequently in people living with diabetes. So here they are totally asymptomatic at earlier stages. It's our job to screen them regularly, at least yearly once. We should send the patient to ophthalmic screening. And if they have proliferative retinopathy and maculopathy, then the options we have is photocoagulation and intravitreal angiostatic treatment. Even though after treatment there will be significant morbidities. Screening approach. Sorry. So move to previous slide. I don't know, the animation is not coming. So here what I had put up is for doing the pregnancy part. If the woman has a previous diagnosis with diabetes and she's going for pregnancy, it is mandatory to check for retinopathy before she gets into pregnancy part. And if she has been diagnosed with the retinopathy, there is 3 monthly checkup is mandatory. Otherwise, there is high chance for worsening of retinopathy during pregnancy. And for other individuals, for type 1 diabetes, after 5 years after diagnosis, we have to start screening. And for type 2 diabetes individuals, at the time of diagnosis itself, we have to send the patients for retinopathy screening. Next. So what we can do in diabetic retinopathy: optimal glycemic control, optimize blood pressure and lipids. And recently from the LENS trial, they have shown that adding fenofibrate to statins have shown to reduce the progression of retinopathy. So moving on to diabetic nephropathy. So around 60% of people with end-stage kidney disease have diabetes mellitus. Next. And screening and diagnosis part as per the consensus statement from ADA KDIGO. So who and when to screen? And type 2 diabetes, yearly starting at diagnosis, and for type 1 diabetes, yearly starting 5 years after diagnosis. And how to screen? You can ask for spot urine ACR and calculating EGFR. So what defines the CKD diagnosis? The persistent urine albumin creatinine ratio more than 30 mg per gram, or persistent EGFR less than 60 ml per minute per 1.73 meter square. So starting with CKD stage 3, that is when your EGFR is less than 60, we have to start the patient on appropriate agents. If we don't check these things, then there is high chance the patient will land up in permanent damage in next 5 to 10 years. So although diabetes is the most common cause of kidney disease, it is important to remember that just because someone has diabetes and kidney disease does not mean that they have diabetic kidney disease. We have to consider non-diabetic kidney diseases in a patient with diabetes and kidney disease. That is, when a type 1 diabetes developing creatinine elevation in albuminuria in less than 5 years duration, or active urine sediments like RBCs, CAS, or if the patient has chronically well controlled blood sugar, and in spite of that the patient is developing nephropathy and rapidly declining EGFR, rapidly increasing or very high urine ACR, and there is no retinopathy, then you have to suspect for non-diabetic kidney disease also. So coming to the prevention of diabetic kidney disease, so what are the factors we should do? Bring the HbA1c to less than 7%, blood pressure control, and advise the patient to stop smoking. Next. So this is the landmark DCCT edict trial, which showed that this is beyond proven beyond doubt that if you bring the glycemic control, that is if you aggressively treat, the rate of albuminuria progression is considerably reduced when compared to the less aggressively treated group. In this study, it has shown that a 50% reduction of microalbumin in original intensively treated group, and you can see the graph also. So when compared to intensive treated individuals, the conventional treated people had a higher risk for albuminuria progression, and this has been the same with EGFR or nephropathy or retinopathy or neuropathy also. So how about ACE inhibitors and ARBs for prevention? So we prescribe telmisartan and enalapril right and left for all individuals with albuminuria. So why can't it be given for to preventing diabetic kidney disease development? So most of the people will say yes, but the fact is this is the best study which has addressed this issue way back in 2009 by Dr. Mayer and colleagues, where they compared enalapril, losartan and placebo, and they followed up the patients for 5 years, and they even biopsied the kidneys of those individuals in the group, and they found out that either enalapril or losartan didn't prevent the development of albuminuria in diabetic patients. So this is the ADA guidelines till date. None of the association advises to prescribe AC inhibitor or ARB for the primary prevention of CKD in people with diabetes who have normal blood pressure, normal urine albumin creatinine ratio, normal EGFR. So AC inhibitors and ARBs are the mainstay of treatment for people with chronic kidney disease. Only when the glomerular hyperfiltration sets in, then the drug has a role. Otherwise, there is no role for primary prevention. So coming to treatment, glycemic control is HbA1c less than 7, blood pressure less than 180, the 130/80, and lower urine albumin, and along with that lifestyle changes, so stopping smoking, weight loss, exercise, diet, and use of medications demonstrated to slow progression of CKD, AC inhibitors, ARBs, phendirenone, SGLT2 inhibitors, and GLP-1 agonist. Next. So the anti-hyperglycemic therapies, yes, metformin definitely will play a role, but be careful. Calculate the EGFR once you are starting. Once the EGFR goes less than 45, then you have to reduce the metformin dose, and less than 30, metformin is contraindicated. And for a SGLT2 inhibitor, you do not initiate if the EGFR is less than 30. Above that, there is no issue at all. And the next big thing is the GLP-1 receptor agonist. Even the recently concluded float trial on semaglutide has shown the 24% reduction in CKD progression. And apart from that, protein intake, you have to advise them to reduce the level of protein intake, that is 0.8 grams per kg per day, and stopping tobacco, physical activity, as previously told in CAD, moderate intensity exercise at least 150 to 200 minutes per week. Next. So if way back in 2020, if you are asked then what are the 4 pillars for CKD management, everyone would have told of metformin, AC inhibitors, SGLT2 inhibitors, and phendirenone. But now we are in 2025. These are the 4 pillars: ARBs and AC inhibitors, SGLT2 inhibitors, phendirenone, and the GLP-1 receptor agonist. Next. So this screening recommendation, annual assessment from diagnosis in type 2 diabetes, 5 years after diagnosis in type 1 diabetes. If the screening is positive, then you monitor twice a year. Moving on to diabetic neuropathy. So this is the most common microvascular complication. It's a heterogeneous group of disorder, and diabetes mellitus being the commonest cause of peripheral neuropathy. Around 30 to 90% of patients with diabetes have peripheral neuropathy. Up to 50% remain asymptomatic. More than 35% have distal symmetric peripheral neuropathy at the time of diagnosis of type 2 diabetes, and early recognition and management is the key. But we have to remember that it is a diagnosis of exclusion. Just because a diabetic patient has a neuropathic symptom doesn't mean it is because of diabetes. We have to rule out the other causes also. So the classification, it's classified into diffuse neuropathy, mononeuropathy, radiculopathy, or polyradiculopathy. And in mononeuropathy, we can get cranial neuropathy like third nerve involvement, peripheral neuropathy, ulnar, median, and femoral nerve involvement, and radiculopathy, lumbosacral polyradiculopathy, or proximal motor amyotrophy, also known as the Burns-Garland syndrome, the thoracic radiculopathy. So in the diffuse neuropathy, then it's classified into diffuse symmetric polyneuropathy and the autonomic being cardiovascular, gastrointestinal, urogenital, pseudomotor dysfunction, abnormal pupillary function, and hypoglycemia unawareness. Next. Symptoms and signs. The earliest symptom is the involvement of small fibers, that is burning sensation, lancinating or shooting, electric shock like pain, tingling and prickling sensation, and exaggerated response to painful stimuli, and pain evoked by contact, that is on putting socks, shoes, everything, the patient says, I have pain. And then the large fiber involvement, there is a negative symptoms. The patient say numbness, loss of protective sensation, unsteadiness of gait, loss of proprioception, and cotton wool sensation, and slipping of slippers. This is a combination of motor neuropathy and large fiber involvement. So these are signs of sensory neuropathy: dystrophic nails, callus, dry cracked skin, charcoal foot. The callus, that is the earliest stage for ulcer development. So for all diabetic patients, we should check their feet. If there is callus, we have to refer to a podiatric specialist to just scrape it off. So signs of motor neuropathy, muscle wasting and muscle weakness. This is clotto. And autonomic neuropathy, we have cardiac, there's reduced heart rate variability, or in advanced stages they can have resting tachycardia. Very rarely they can go in for orthostatic hypotension also. And gastrointestinal, persisting nausea, vomiting, there's diabetic gastropathy or enteropathy, diarrhea. Sometimes they can have alternating constipation and diarrhea. And nocturnal diarrhea is typical for diarrhea secondary to diabetes mellitus. And genitourinary, they will have erectile dysfunction, urinary incontinence, decreased libido, and pseudomotor dysfunction, as gustatory setting and hydrosis of feet and hyperhidrosis of upper limb can be there. Pupillary, there might be impaired pupillary light adaptation, and very prolonged uncontrolled diabetes can lead to hypoglycemia unawareness. So diagnosis, remember, it is always a diagnosis of exclusion. So in the workup wise, we have to ask for renal function, thyroid function test, and ask for symptoms of vasculitis and infections like HIV, hepatitis B, Lyme disease, and nutritional deficiency. Definitely we have to ask the history of vegetarian thing, because B12 deficiency itself can mimic neuropathy symptoms, and drugs, alcohol. I'll come into detail about the drugs later. So this is a suggested initial etiological workup for distal symmetric polyneuropathy, HbA1c, vitamin B12, serum protein electrophoresis, thyroid function test, and metabolic panel, sodium, potassium, calcium should be there. So diagnosis for type 1 diabetes, more than 5 years, you have to assess for peripheral neuropathy annually. For diabetes type 2, assess all patients annually. Next. So this diagnostic step for how to differentiate between small fiber neuropathy and large fiber neuropathy. For small fiber neuropathy, thermal cold hot discrimination, there will be it might be reduced or absent, and pinprick sensation might be reduced or absent. For large fiber neuropathy, ankle reflexes can be reduced or absent, and vibration threshold will be reduced, and 10-gram monofilament test can be used to detect those things. So it's mainly clinical. Only 50% of the individuals are symptomatic. So ask for symptoms of both the large and small nerve fiber. Next. So this is a monofilament test. You have to use the 10-gram monofilament test. There are 9 spots are there. If 4 out of 9 is positive, then it is diagnostic of neuropathy. Next. So key points to remember, always go from distal to proximal because it's a length dependent neuropathy. There's something called as dying back phenomenon, because I haven't mentioned about the pathophysiology. There is something called as advanced glycation end products that actually damages the distal axons, distal neurons, then it progresses to the proximal neurons. That's why we have to always check from distal to proximal. So when to refer or go for advanced test? The clinical features are atypical, the diagnosis is unclear, different etiology is suspected, there is ESR elevation, ESR more than 100, and atypical features like motor greater than sensory neuropathy, and rapid progression is there. Then you go for advanced tests like nerve conduction studies for large fiber, skin biopsy for small fiber neuropathy, and corneal confocal microscopy. So moving on to the management approach for the diabetic neuropathy. Next. So neuropathic pain principles, all treatable causes of neuropathic pain should be excluded, especially in patients with diabetes mellitus. You have to ask for the neurotoxic medications, alcohol overuse, monoclonal gammopathy, vitamin deficiencies, overuse, and renal disease. Next. So definitely we all know that about the chemotherapy agents, everything will lead to a neuropathy. So I'm not going depth. Next. And this is very important. So most of the diabetic patients, they will have some kind of infections and will be prescribing a lot. So linezolid can lead to sensory polyneuropathy, metronidazole, all forms of neuropathy will be nitrofurantoin, sensory motor axonal neuropathy. And if the patient is having TB, think about isoniazid and amiodarone, phenytoin, and the main thing is vitamin B6. Its overuse can cause is a common cause for painful sensory ganglionopathy, and it resolves with cessation of the tablet. So medication management, FDA has approved duloxetine and pregabalin as a first-line medications to treat diabetic neuropathy. Gabapentin is often used as a first-line drug, and FDA also has approved 8% topical capsaicin patch. And role of tapentadol is rarely useful, and whenever you are using pregabalin or gabapentin, always check the EGFR. Next. So the main two drugs are pregabalin and duloxetine. Pregabalin 150 to 600 mg per day in 2 to 3 divided doses. So be careful when you are going beyond 200. And if the patient is having renal dysfunction, don't go beyond 300 and all. It will knock off the patient. So and again for gabapentin, 300 to 1200 mg 3 times daily. That's a maximum dose of 3600 mg can be given, but rarely it will be more than 600 will be needed. Again, be careful in CKD patients. Next. So these are multimodal options for painful polyneuropathy. The first level therapies is main thing is pregabalin, gabapentin, duloxetine, and you can also try nortriptyline. And the complementary therapy is alpha lipoic acid 600 mg per day and exercise. So the aerobic exercise 4 hours per week is can provide improvement in peripheral neuropathy. The second level therapies include tricyclic antidepressants, venlafaxine, valproate, and lidocaine patches. Next. So a few points about alpha lipoic acid. Because of its antioxidant property, it has shown some benefit in painful diabetic neuropathy. But there is conflicting evidence in last studies. The Aladdin 3 trial was a 7-month multicenter randomized control trial which showed improvement in the neuropathy impairment score, but not in the total symptom score. But the Sydney 2 trial, it compared 3 doses, 600 mg, 1200 and 1800 mg to placebo. All 3 doses are superior to placebo in pain relief, but not to total symptom score. And the Northern 1 trial suggested patients with the fewer comorbidities were more likely to improve the lower limbs. So the common adverse effects being nausea and acid reflux, most commonly discontinued because of its ineffectiveness. Next. So the lifestyle interventions, definitely doing aerobic exercise has shown benefit because it reduces the oxidative stress. At least we have to advise the patients to do moderate physical activity, that is 150 minutes per week with no more than 2 consecutive days off, with resistance training, that is 2 to 3 sessions, that 15 minutes each of some abdominal crunch, squatting or lifting weight. That will be beneficial for the improvement of painful neuropathy. Next. So these are complications, ulceration, neuropathic edema, Charcot foot, and callosities. So initially I had shown the picture of callus. If that is not addressed properly, then this stage with ulcer will set in. Next. So prevention of foot complications, at each office visit, make it mandatory to inspect the feet, manage any ulcer infections or deformities aggressively, and refer to podiatric specialty if required. Next. So caring for the feet, we have to advise the patient to check their feet every day before they are going for sleep, and we have to advise them to check for cuts, blisters, sores, swelling, dry skin, cracks. Next. So wash the feet every day, but we are not to dip in hot water, only in warm water. Do not soak dry feet well. Be sure to dry between the toes. You can use moisturizers also. Next. So wear shoes that fit well and protect the feet. Athletic or walking shoes are good for daily wear. Better to avoid plastic shoes. Next. So the cutting the nails, this also has some, if they don't go close to the borders. Because of that, they can end up in gangrene also. Next. So the key points are, diabetic neuropathy is actually a diagnosis of exclusion. Fix the cause first. Food care advice for all. Pregabalin used in adequate dose. Whatever medicines, pregabalin in anything, neuropathy, nephropathy, telmisartan, anything, unless you bring down the HbA1c to less than 7%, even if you use 10 to 15 tablets, nothing is going to be of beneficial to the patient. So always we have to, if we think glycemic control is good, we have given appropriate medicine, but still there is a component known as a genetic risk. We have to always keep that in mind. Thank you.
Thank you, sir. Any questions from the audience? Thank you, sir, for such a dynamic and informative session, and your ability to break down complex concepts into practical insights was incredibly helpful. Now, I kindly request Professor Dr. Sahaya Jose, Deputy Director, Professor and Head of Department of Orthopedics, to honor our speaker. Now, questions to students. What are the early complications, microvascular complications of diabetes? Raise your hands. What tool or test is used for diagnosing diabetic neuropathy?
Diabetes, neuropathy. One touch test. Come. One of them.
We are looking forward to learn actionable strategies that we can incorporate into our clinical practice to improve patient outcome. Hereby welcoming Dr. Sudhakar, Consultant Diabetologist, Sri Diabetes Specialties Center, Nagarkoil.
Good afternoon. Good afternoon, professors and students and other doctors. First of all, I have to thank Dr. Prince Pius for giving this opportunity. See, today my topic is lifestyle management in type 2 diabetes. Next. So, lifestyle management for type 2 diabetes primarily focus on 4 things. Healthy diet, regular physical activity, weight management, consistent blood sugar monitoring, and stress control. So all this is enough for some patients to manage their blood sugar level. Next. So medical nutrition therapy is crucial for treating type 2 diabetes. So some clinical trials showed that medical nutrition therapy have demonstrated 1 to 2% of reduction of HbA1c in type 2 diabetic patients. As obesity is an important factor and associated with insulin resistance, decrease in the body weight is very important in pre-diabetic and diabetic patients. Next. So the concept of medical nutrition therapy varies from country to country. Usually Americans and European countries follows carbohydrate counting, spelling mistakes. So carbohydrate counting means measuring the amount of carbohydrate in food and drink what we consume. So one carbohydrate servings is equal to 15 grams of carbohydrate. So this helps to match the insulin dosage or the oral hypoglycemic agents to the amount of carbohydrate what patient intake. So the carbohydrate used is complex carbohydrates are preferred. Complex carbohydrates are from whole grain, vegetables and legumes. So recent studies showed that vegetable based low carb diet reduce the all cause mortality and CVD mortality rate and is associated with favorable changes in the reduction of risk for CVD. Next. So what RSST says, medical nutrition therapy based on type, amount and frequency. So carbohydrate limited to 50 to 60% of the total calorie intake. Complex, the carbohydrate used is complex carbohydrate with low GI and low glycemic load. Fiber 25 to 40 grams per day. Protein intake about 15% of their total calorie intake. It's the protein intake depends upon the AH, sarcopenia and renal dysfunction. So non-vegetarian source of proteins are high quality protein. So red meat should be avoided. Next. So fat limited to less than 30% of their total calorie intake per day. So the sources from nuts and seeds, oil with high MUFA and PUFA, monounsaturated fatty acid and polyunsaturated fatty acid. For non-vegetarian, 100 to 200 grams of fish per week, or for oil and for oil, vegetable oils like soya bean, safflower and sunflower. But in our market, the sunflower we are in our the market, sunflower oil available in our markets are not 100% sunflower oil. Most of the brands maximum they are having 30 to 40% of sunflower oil, remaining are refined oils. So better to avoid sunflower oil from our market. Nuts and seeds like walnuts, flax seeds are recommended. Groundnut oil and mustard oils are suitable based on their fatty acids. So saturated fatty acids should be avoided, and if the patient is taking or if you are advising, it must be less than 10% of the total calorie per day. Next. Avoid saturated fat like butter, ghee, coconut oil and vanaspati. Avoid reheating and refining of cooking oil. The salt intake must be less than 5 gram per day, and the sodium intake is less than 2300 milligram per day. Artificial sweeteners should be avoided as they alter the diversity of the gut microbes and increase insulin resistance. Next. So ADA recommendation of calorie intake. The patients under the category of overweight, that is BMI greater than 25, and obese, the BMI greater than 30, the calorie intake must be 500 to 1000 lower than the required calorie for their weight. And ASD, reduce calorie intake and increase expenditure for patients with BMI greater than 25. So that BMI moves towards the recommendation range of from 18.5 to 24.9. Next slide. So when we categorize the BMI, and less than 18.5 it's underweight, 18.5 to 24.9 are healthy weight, and 25 to 29.9 are overweight, 30 to 34 are obese, and greater than 35 are extremely obese. Next. So this Japanese Diabetic Society, Japanese Athero Society, Japanese Society for Study of Obesity recommended as per the as per the ideal body weight. Here the ideal body weight is calculated by height in meter square into 22 kg per meter square. So the total energy requirement is estimated as for 25 to 30 kilocalorie per kg ideal body weight per day for low level activity, and 30 to 35 kilocalorie for usual level activity, and greater than 30 kilocalorie for heavy level activity. So for obese patients, 20 to 25 kilocalorie per kg ideal body weight. Next. So the next thing is the physical activity. So in lifestyle management, next to diet, is a exercise. The exercise must be regular and aim the patient has to aim for at least 150 minutes of moderate intensity exercise per week. So the exercise will be in variety, so it won't get bored. So like the activities like walking, swimming, cycling and strengthening. So before I heard we have to advise we have to choose the type of exercise for the patients. So according to the patient physical weight, their diet pattern and their health issues and the comorbidities, we have to decide the duration and intensity of the exercise. Next. So weight management, healthy weight goal. If overweight, try to lose weight. Any small amount of weight reduction is helpful to reduce the blood sugar, reduce the blood pressures, cholesterol levels. So calorie awareness, monitor calorie intake and adjust eating habits accordingly. Next. Next thing is the blood sugar monitoring. Regular testing, regularly check the blood sugars to understand how the food and activity affects the blood glucose. While doing self glucose monitoring, like doing capillary blood sugar, better to advise the patient to do pre-meal and post-meal blood sugars. That is morning fasting and postprandial, then before lunch and after lunch, and before dinner, after dinner. If possible, we have to advise the patient to do the blood sugar in the around 3 o'clock early morning, because that is the time most of the patient go for hypoglycemia. So while doing blood sugar pre-meal and post-meal, see patient itself self-evaluate that which food increase the blood sugar and which food is suitable for to control the blood sugars and all. Patient can evaluate by themselves. So it's advisable to do blood sugar level in different times, and it must be pre-meal and post-meal. Then comes to the ambulatory glucose profile. Say the ambulatory glucose profile is now available in our country, and it's we'll get sensor even through Amazon or some online thing. So the ambulatory blood glucose, if now the sensor available in India is from Abbott Freestyle Libre. So it's lasts for 14 days. Once we fix an sensor, it will continuously take reading from the interstitial fluid in the subcutaneous space, and it will last for 14 days, and it will give a daily basis sugar levels, and we can take a weekly basis weekly base data we can take, and it will give a it will show the whenever the blood sugar goes up and whenever the patient go for hypoglycemia, and we can get a curve, and we can see how much of the time the patients are in the target blood sugar level, and how much time they go for hypoglycemia and go for high blood sugars level. And with the food variations, we can see how the blood sugar goes up and or it's come down. And if the patient is taking insulin, what amount of insulin will maintain the blood sugar, or what amount of insulin if you take, it will go for hypoglycemia and all. We can clearly know by using ambulatory glucose profile. So next thing is adjust treatment based on results. Necessary adjustment of medications and or lifestyle change based on blood sugar readings. Next. So ABC management means A for A1C, B for blood pressure, C for cholesterol, and S for stopping smoking. Next. So A1C is the test. It will give the average blood sugars level for from last 2 to 3 months, and for a up to 5.6 is normal. For a to diagnose pre-diabetes, the A1C is between 5.7 to 6.4, and any blood sugar, any A1C 6.5 and above is diabetes. Keeping A1C below 7 is indicates a good glycemic control, and if it is between 7 to 8, it's okay, fine, fair, and any A1C more than 8 is poor glycemic control. So BP, we have to maintain the BP under 130/80. Next. So cholesterol level, you have to maintain LDL below 100 and triglyceride below 150, and we have to maintain HDL above 40. Next. So when following diabetic management, there is no place for smoking. We have to advise the patient to quit smoking. If not possible, you have to reduce the amount of smoke and the duration of the frequency of smoke. Slowly we have to reduce and we have to stop. So it will reduce by quitting cigarette smoking. We can reduce risk for developing macrovascular disease like heart attack, strokes, and microvascular disease like renal dysfunctions, retinopathy, and it will improve blood pressure control and cholesterol level control, improve blood flow. It will increase the physical ability. Next. Alcohol. So some textbook says moderate alcohol consumption does not have major effect on long-term blood glucose control in patients with diabetes, but the risk associated with the alcohol consumption include hypoglycemia, weight gain, and hyperglycemia. Next. Stress management. When it comes to stress management, there are a lot of relaxation techniques. So deep breathing, meditation, yoga, and patient should have a good sleep. So to ensure adequate sleep to maintain hormonal balance and overall health. Next. So education is more important, especially in country like India. We have large population of diabetes, and as physicians or doctors, we have less time to spend time with the patients and educating. So each and every hospital or a clinic, we need a diabetic educator, and diabetic education is very must for patients to keep their blood sugar under control, blood pressure under control, and reducing or preventing complications. Next slide. So in conclusions, so we have to in lifestyle management, we have to follow 4 things, like 4 Vedas. We have to follow 4 things. One is good glycemic control, strict diet control. Second thing, regular physical activity or exercise. Then regular medications and regular checkups. So to boost insulin sensitivity and blood glucose regulation, hypoglycemic management, weight management, cardiovascular risk reduction, and muscle development, patient need lifestyle modifications. Thank you.
Thank you, sir. Any questions from the audience? Thank you, sir, for an excellent and enlightening session. Now I kindly request Professor Dr. Vasaginathan, Head of Department of Anesthesia, to honor the speaker. Questions to students. One carb serving is equal to how many grams of carbs? Please raise your hand. One carb serving is equal to how many grams of carbs?
What is your name?
What is the HbA1c in diabetic patient? HbA1c. What is the amount of salt consumption in recommended by ADA? We are honored to welcome Dr. Jayaram Kosalram, Assistant Professor of Medicine, Kanyakumari Government Medical College, Asaripallam, who will be sharing their expertise on the treatment of type 2 diabetes mellitus, specifically focusing on oral hypoglycemic agents and insulin therapy.
Good afternoon to all. Already the lunch time, so I think everyone will be very hungry. I will short my topic I will cover my topic very shortly. Okay. And I thank our principal sir and the organizing committee for giving this opportunity. My given topic is treatment of type 2 diabetes mellitus. First we will see the insulin. The insulin was discovered in 1921 by Banting and Best. The insulin is a 2-chain polypeptide having 51 amino acid with molecular weight about 6,000. The A chain has 21 while the B chain is 30 amino acid. Insulin is synthesized in the beta cell of pancreatic islets. The beta cell have a glucose sensing mechanism depends on the entry of glucose. Next. Coming to the mechanism, the glucose entry and the metabolism lead to activation of glucose sensor and production of ATP, which inhibit ATP sensitive potassium channel, resulting in increasing intracellular calcium and leading to exocytotic release of insulin. Then another one, the glucose when enter into the oral, they generate incretins from the gut which act on beta cell in the pancreas to cause anticipatory release of insulin. The incretin, major incretins are glucagon like peptide 1, glucose dependent insulinotropic polypeptide, vasoactive intestinal peptide and pancreozymin, cholecystokinin, etc. Next. So, coming to the oral anti-diabetic drugs, some around 8 and some more groups are there. So, first you will see the groups are the bigonide, sulfonylurea and non-sulfonylurea like meglitinide, phenylalanine analogs, GLP-1 receptor agonist, then DPP-4 inhibitors,
that dipeptidyl peptidase 4 inhibitor, sodium glucose co-transfer 2 inhibitors. And glucose dependent on is DPP4 inhibitors and GLP-1 analogs. Then coming to the insulin resistant, mainly metformin and pioglitazone. Then retard the carbohydrate absorption, alpha glucosidase inhibitor. Then another one miscellaneous, mainly SGLT2 inhibitor. It mainly excrete the glucose in the urine. Next. Next. First you will see the bigonides. The only one drug available is metformin. Metformin acts intestine, liver, skeletal muscle. In intestine, increase anaerobic glucose metabolism. In liver, decrease gluconeogenesis, decrease glycogenolysis, decrease fatty acid oxidation. In skeletal muscle, increase mediated glucose uptake, increase glycogenesis and decrease fatty acid oxidation. Next. So metformin, while we are taking the drug, the way it will be neutral, does not cause hypoglycemia and decreased cardiovascular event. This is the drug, first line drug, inexpensive, extensive experience, and the maximum tolerated dose is 2 grams per day. It can be given in a 2 to 3 divided doses. The adverse effects are diarrhea, nausea, lactic acidosis, vitamin B12 deficiency. The contraindication in renal insufficiency and the eGFR less than 30, heart failure, hospitalized patient and acidosis. And the average HbA1c reduction is 1 to 2%. Next. Next. Coming to sulfonylurea, acts on the sulfonylurea receptor 1 in the membrane of pancreatic beta cell and blocks potassium ATP channel and increases the calcium in the intracellular, and the calcium ion promotes the fusion of insulin containing intracellular granules with the plasma membrane and exocytotic release of insulin. Short onset of action, lower postprandial glucose. The adverse effects are hypoglycemia, weight gain, and contraindicated in renal and liver insufficiency. Next. And we will see the drugs. The first generation tolbutamide, it's not currently not available. And the second generation, the 4 drugs are there, glibenclamide, gliclazide, glipizide and glimepiride. Among these drugs, the short acting is gliclazide and can be given in the elderly patient. Sorry, elderly patient. And glibenclamide in the dose of 2.5 to 15 mg per day in 2 divided doses, and gliclazide can be given 40 to 240 mg in a divided doses, around 2 to 3 divided doses. And gliclazide 5 to 20 milligram per day in a 2 divided doses. Glimepiride 1 to 6 mg per day can be given OD or once a day or twice a day. The average HbA1c reduction is 1 to 2%. Next. This is also secretagogues, meglitide and phenylalanine analogs. Same like sulfonylurea, the action also same. Increase insulin secretion, faster onset of action and short lasting insulin release. Lower postprandial glucose, lower risk of hypoglycemia, The adverse effects are headache, dyspepsia, arthralgia, and weight gain. Contraindicated in liver and renal insufficiency. Rapaglinide is a drug, can be given 1 to 8 mg per day and given 3 times a day, and natiglinide 180 to 480 mg per day and can be given 3 times a day. And the average HbA1c reduction is 0.5 to 1%. Next. The another group of drugs, dipeptidyl peptidase 4 inhibitor, the DPP4 inhibitor, inhibits the degradation of native GLP-1 and thus enhance the incretin effect. DPP4 inhibitor promotes insulin secretion in the presence of hypoglycemia or weight gain. In the absence of hypoglycemia or weight gain. Reduced dose with renal insufficiency except for linagliptin and teneligliptin. Avoid this agent in the patient with pancreatic disease or with other significant risk factor for acute pancreatitis like heavy alcohol use, increased triglyceride and hypercalcemia. Next. So common drugs we are using is sitagliptin, vildagliptin, linagliptin, teneligliptin and saxagliptin. The sitagliptin we can give once a day, 100 mg per day, or we can give in divided doses 50 mg twice a day, and vildagliptin also 100 mg per day and we can give in 2 divided doses. Linagliptin 5 mg per day in once a day, teneligliptin 20 mg per day once a day, and saxagliptin 5 mg per day also given in once a day basis. Then the HbA1c reduction is around 0.5 to 0.8%. Next. The another group of drug, sodium glucose cotransport 2 inhibitors. So it's the SGLT2 inhibitors. The SGLT2 exclusively in the proximal convoluted tubules in the kidney. So the SGLT2 inhibitors inhibits glucose reabsorption, lower the renal threshold for glucose and lead to increased urinary glucose excretion. Also impair proximal reabsorption of sodium. The glucose lowering effect is insulin independent and not related to change in insulin sensitivity or secretion. Promote modest weight reduction, diuretic effect and reduction in systolic blood pressure, reduce cardiovascular disease event and all cause cardiovascular mortality in the patient with type 2 diabetes and cardiovascular disease. Reduce hospitalization in heart failure, reduce progression of diabetic kidney disease. Next. Should not be prescribed for the patient with type 1 and pancreatogenic form of diabetes mellitus associated with insulin deficiency. Should not be initiated in the patient with stage 3B CKD. Urinary and genital mycotic infection are common. Euglycemic decay in sick patient. Increased risk of bladder cancer has been seen in dapagliflozin. The common drugs are canagliflozin, dapagliflozin and empagliflozin. Canagliflozin at the dose of 100 to 300 mg per day, and dapagliflozin at the dose of 10 mg per day, and empagliflozin at the dose of 25 mg per day. And the average HbA1c reduction is 0.5 to 1. Next. Thiazolidinediones reduce insulin resistance by binding to the peroxisome proliferative activated receptor gamma, PPAR gamma nuclear receptor. The PPAR gamma receptor is found at the highest level in adipocytes, decrease insulin resistance, increase glucose utilization, lower insulin requirement. The adverse effects are peripheral edema, heart failure, weight gain, fractures and macular edema. The fractures especially in the post-menopausal woman. And contraindicated in heart failure, renal and liver insufficiency. Pioglitazone is given 15 to 45 mg per day. And HbA1c reduction is around 0.5 to 1%. Next. Alpha glucosidase inhibitors. It is a complex oligosaccharide which reversibly inhibits alpha glucosidase, the final enzyme for the digestion of carbohydrate in the brush border of small intestine mucosa. Decrease GI glucose absorption, reduce postprandial glycemia, drug taken just before each meal. So commonly commonly we are using drugs is O-glucose at 0.2 mg to 0.3 mg per meal. Adverse effects are GI flatulence, diarrhea, abdominal distension, elevated liver function. Test in elevated liver function and contraindicated in renal liver insufficiency, inflammatory bowel disease, gastroparesis. The average reduction of HbA1c is around 0.5 to 0.8%. Next. GLP-1 receptor agonist. This is injectable as well as oral. GLP-1 enhance the incretin effect, increase insulin secretion, decrease glucagon, slow gastric emptying, satiety. Weight loss does not cause hypoglycemia unless combined with another insulin secretagogues or insulin. Decrease cardiovascular event. And the adverse effects are nausea and pancreatitis. Contraindicated in renal disease, medullary carcinoma of thyroid and pancreatic disease. The only drug available in the oral form is semaglutide. The preparation is available in 3 mg, 7 mg and 14 mg given in the empty stomach. And lixisenatide, it's the drug is injectable 15 days once, and dulaglutide weekly once, liraglutide once daily, exenatide twice daily. And the HbA1c reduction is around 0.5 to 1%. Next, coming to the insulin preparation. Here the two type of preparation is available. One is conventional and another one is analog. These both insulin short acting and long acting is available as an analog, aspart, glulysin, lispro. These analogs are, the onset of action is very short. Within 10 minutes, the onset of action will be there, and the peak around 30 minutes to 1.5 hours, and the duration of action is around 3 to 5 hours. Whereas the regular insulin, the onset will be start little late, around 30 minutes started, and the peak around 2 to 3 hours, and the duration of action is around 4 to 8 hours. So the short acting analog should be given 10 minutes before each meal, 10 minutes before each meal, and the regular should be given 30 minutes before meal. And inhaled human insulin also available. And coming to the long acting, both analog and regular, the analog is degludec, detimer and glargine. Among these three, the very long acting one is degludec, around more than 24 hours, around 42 hours. And the detimer is around 12 to 24 hours, and glargine is around 20 to 24 hours. There is no peak in these drugs. No peak action will be there. There is no peak action, and the onset is around starting from the 1 hour to the degludec is around 1 to 9, and detimer is 1 to 4 hours, and glargine is around 2 to 4 hours. But whereas the NPH, that conventional one, is the onset is 2 to 4 hours, and the NPH has peak action around 4 to 10 hours and the average duration is around 12 hours. Then there's some combination with short acting and long acting is there in both in the analog and conventional one. Like 25, that 20 with the less number is the short acting and the more number is the long acting. That is 25 is a short acting Lispro and the protamine Lispro is the long acting one. So it will 75%. The same like 30-70 and 50-50. And in the conventional one, the 30 is the regular and short acting and the 70 is the NPH, long acting. So as well as the 50-50 also available. Next. So in this two picture is there, A and B. First one is the mixed both short acting and long acting with conventional one, regular insulin plus NPH. So here if you are giving 2 times, one at the morning and one at the evening, half an hour before food. So the peak of the regular insulin will be in the breakfast, but the second dose if you are giving and the peak will be at the dinner. And intermittent, the lunch time there is some peak due to the NPH only, not with the regular one. So sometimes patient will not adequately, the adequate dose will not be delivered in this insulin by giving this insulin. So and the patient may develop hypoglycemia in the night, midnight or early morning. Okay. So coming to the bolus basal regimen, the basal bolus regimen, here the short acting as well as independently we are giving 3 short acting at before every meal like breakfast, lunch and dinner, and we are giving the night time we are giving the long acting analog. So here the basal means the long acting and the bolus is the short acting. The bolus is adequately for the each meal and the basal insulin will cover our basal need. Okay. So less hypoglycemia is occurring in this regimen. Okay. Next. So some how to deliver the insulin by syringe. The vial, the medicine is in the vial and we will take the medicine from the vial with syringe and we can give to the patient one. Then pen insulin. Pen insulin single use also there and multi-use. The multi-use we can, the inside the cartridge is there, then we can replace the cartridge. Okay. And the insulin pump, it will deliver continuously. Okay. Next. Before that, the oral anti-diabetic drugs have its combination. Now we are using more combination in our clinical practice. So the combination, so a number of combination is there. So dual drug, triple drug, okay. For example, sulfonylurea metformin, sulfonylurea metformin pioglitazone, sulfonylurea metformin oglibose, sulfonylurea DP4 inhibitor metformin, sulfonylurea with SGLT2 and metformin, and sulfonylurea, SGLT2 metformin, DPP4 metformin, and then SGLT2, DPP4 and metformin, like that. Double, triple drug combinations are available. These drugs, combination drugs are, reduce the pill burden for the patient. Reduce the pill burden for the patient, and some more rate also will be less compared with the monotherapy. We are giving multiple drugs with a single if you are using a drug. Okay. So the combination of these drugs are clinically we are using in our for our patient. Next, the take-home message. Previous slide. Metformin is the first-line oral anti-diabetic drug. Glycoside is preferred in elderly. DPP4 inhibitor of choice in renal failure is linagliptin, dapagliflozin is useful, or SGLT2 inhibitors is useful in the heart failure cases. GLP-1 analog are preferred in obese diabetic patient. Insulin is the treatment of choice in the gestation diabetes mellitus. Next. Remember, all secretagogues and alpha glucosidase inhibitors are ideally taken before meals. All secretagogues and alpha glucosidase inhibitors are ideally taken before meals. Avoid oral anti-diabetic drugs in seriously ill and hospitalized patient, especially glucose-independent secretagogues cause hypoglycemia. Metformin cause lactic acidosis. SGLT2 inhibitors cause euglycemic decay. Thank you.
Thank you. Thank you, sir. Any questions from audience? I kindly request Professor Dr. Anthony David, Medical Superintendent of KMMC, to honor the speaker. Now, questions to students. Which is the first line? Please raise a hand, okay? Which is the first line drug used in the management of diabetes mellitus? Which is the glucagon-like peptide GLP-1 analog available in oral form? Once again, which is the GLP-1 analog available in oral form? How many amino acids does human insulin have? So, the answer to the question GLP-1 analog that is available in the oral form is semaglutide. We are excited to learn about the updated approaches for managing type 2 diabetes, ensuring that we are delivering the best possible care to our patients. Let's give a warm welcome to Dr. Prince Pius, Professor of Medicine, Kanyakumari Medical Mission Research Center, Medical College and Hospitals, Muttom, as he takes us through Research Society for the Study of Diabetes in India guidelines.
So thank you for the introduction. Actually, I don't want to take much of your time. Anyway, you have now we are going to finish the talk. Actually, after hearing this lecture, you are more confused, isn't it? Actually, see, there are many drugs, many tests. What to do? See, the treatment of diabetes, type 2 diabetes, we have to stick on to 4 pillars. One is diet. Second is exercise. Third is knowing about the disease. We have to teach the patient every visit what is diabetes. Fourth one is the drugs. I will give the 4th place for drug. First place is for diet. Second place for exercise. Third place for knowing the disease, what it is, what are the complications. See, you ask any patient, they will say, what is diabetes? Just passing sugar in the urine, that's all. They don't know anything about diabetes. See, diabetes is the vascular cum metabolic disorder. So it will affect all the parts. So what diet you will give? See, diet, there is no fixed diet. This is the previous slide. First slide. So So what diet you will advise? See, before advise the diet, you should ask the patient what diet he is taking in his home. We should modify his diet. There is no one diet for fix. See, I like mutton. Some other person will like fish. Some other person will like vegetarian. So there is no fixed diet. So before advising diet, the doctor should know what is diet. So we should advise according to, which is individualized. This is the RSSD guidelines, is the diet, everything is individualized. There is no shoe fit to all. Attitude should go. So we have to advise the diet according to the patient interest and according to the patient finance and according to the patient willingness. There is no such diet. Don't eat in the morning, there is no such diet. So the idea is we have to reduce the calories and we have to reduce the carbohydrates, and you give more protein, fat. So low carb diet is the best diet. That the diet itself we can talk for 1 hour. So you understand there is a low carb diet. Diet is individualized. Then exercise. What kind of exercise you will advise? Any exercise. What exercise? See, simple is walking. That's all. That is why we are advising all the patients to walk and walk. See, some person will say, see, I am a very busy person. I find no time to walk. Then what you do? Then you advise high intensity exercise. What is high intensity exercise? Dancing. Dancing is the best exercise. See, now the Zumba dance. So the dancing is, see, 12 to 15 minutes of dancing is equivalent to 1 hour of walking. See, if you don't find time to walk, you simply dance. That is enough. Or do some, play some games. See, some, then that again individualized. See, some person is a manual worker. If you ask him to go for walking in the morning, what is the use of it? So again, the exercise is individualized and you should make, see, first we should know what is exercise. See, all the guidelines say is 150 minutes per week. That is half an hour per day for 5 days in a week. This is not enough. This is not enough for our country, for our people. See, we should advise them at least 1 hour per day walking. Then only the patient will walk at least for 30 minutes. So 1 hour walking is the goal for our people. So again, the exercise is individualized. They can walk, they can run, they can swim, they can cycling. If they don't find time, they can dance. So they can do any kind of exercise. Then third thing is the understanding the disease. Every visit, you should tell the patient, this is the drug, this is the disease not only with the sugar. This disease will affect all the blood vessels. So all the blood vessels is everywhere in our body there is blood vessel. So all the blood vessels will get damaged. So they may develop all the complications. So you should make them understand this point. Every visit you have to talk about something about the disease. And fourth one is drugs. Now, after listening to Dr. Jairam's lecture, you know, previously we had only metformin and sulfonylurea. No other drug. Now we are having plenty of drug. Which drug use? Which drug for which patient? We are we don't know which drug to use which patient. So that is the guidelines we are giving. From the RSSDA is giving the guideline based on what? That is the topic today. So for any patient, first start with metformin. That is the rule. If the metformin is unless otherwise not tolerated by the patient. So first slide. So this is after the drug is after diet, after exercise, and after metformin. What is the second drug you will select? So always patient-centric approach. The first line therapy is always metformin. Next. So the second choice based on the patient preference. See, most of the patient will have some other comorbidities, diabetes with hypertension, diabetes with some kidney disease, or some problem they will have. So all the diabetic patient, otherwise it is a rule, look for hypertension in all diabetic patient. All hypertension patient look for the diabetes. That is the rule. So most of the patient, they will have hypertension. So not just treating the sugar is not enough. We have to treat the patient as whole. See, most of the, in diabetes itself is a post-infarct state. So we have to give statin, primarily prevention, we can give for all the diabetic patients. So if you, any of your relatives taking this tablet for diabetes, you look in the prescription whether he is getting statin. You can give statin for all diabetic patients, nothing wrong in it. So we have to tackle the other comorbidities also. So the drug should not have any side effects. Most of the side effect is hypoglycemia. So the drug should not produce any hypoglycemia or weight gain. Next. So this is the approach. See, after metformin, according to the age, according to the BMI, according to the CKD, if the patient is having A, B, C, D, CKD, or duration of diabetes, how long he is having this diabetic. So he established this cardiovascular disease, his financial condition, his glycemic status. So can be used in patient with dialysis. GLP-1 can be used. These are the add-on drugs. Next. So insulin can be used in any stage of repair is false. Next. So duration of diabetes, if the patient is having a long duration of diabetes, the most of the beta cells will be exhausted. So the patient will not respond if you give a secretagogue like sulfonylurea. So most of the patient needs insulin to control the diabetes. And GLP-1 receptor agonist also can be given this patient because of its low risk of hypoglycemia. SGLT2 inhibitor and alpha glucosidase inhibitor also may be useful because it acts in other than the beta cell. So it can be used. Next. So established cardiovascular disease, the GLP-1 receptor agonist and SGLT2 inhibitor is preferred. And heart failure also, even independent of diabetes, now they are using SGLT2 inhibitor in heart failure. And glimepiride and glycoside is preferred over the other conventional sulfonylurea. Alpha glucosidase inhibitors are useful because it will control the postprandial hyperglycemia. Pioglitazone should not be used because of its fluid retaining character. Next. So financial concern. This is in our country we don't have people they don't buy the medicines. So sulfonylurea can be given, and low cost this DPP4 and SGLT2 inhibitors, pioglitazone can be given. Insulin, instead of analog insulin, we can use conventional insulin. Next. Glycemic status. Which drug will decrease the HbA1c is the insulin. Insulin is this order: insulin, then sulfonylurea, metformin. So this is the order we have to use. Next. So hypoglycemia concern. So these the individuals, the hypoglycemia poses a risk. So patient with established cardiovascular disease, elderly patient suffering from CKD, patient cannot perform self-monitoring of blood glucose, patient who stays alone in remote areas, shortened life expectancy, having hypoglycemia unawareness, autonomic nerve. These patients are very prone to get hypoglycemia. Next. So this patient, we can high risk of hypoglycemia, we can use these drugs, GLP-1 and SGLT2 inhibitor are the first choice with the metformin. The drugs which can be avoided are glenides and sulfonylurea and insulin. Next. So this is the 2025 guidelines, ADA guidelines. Here also they are divided after metformin, cardiovascular and kidney risk reduction. So this is one group, and another group is the weight maintenance. So like our RSSD guidelines, they are also divided the patient and drugs, the atherosclerotic cardiovascular risk. The drugs are same, GLP-1 and SGLT2 inhibitors, so like that only. They are also the same, they are also continuing. Next. This is European and this is the European Diabetes Association and ADA consensus statement. So here also after metformin, established cardiovascular disease and CKD, this is one group. If the patient is not having this, without this cardiovascular disease and CKD is another group. So this group again GLP-1 and SGLT2 inhibitor, and there the compelling need to minimize hypoglycemia, the drugs which I have already told, and the patient want to promote weight loss, so their drugs, and cost is the concern the other group. So the same type of guidelines, they are followed world over. Next. This is the summary of what I told now. Next. So take home message is, now after metformin, the therapy is individualized according to the patient's problems, patient's comorbidities, patient's disease. There is no one size fit to all treatment in patients with diabetes. This is the take home message. So now we have to study the patient first. The patient is individualized. According to his interest, you prescribe diet, you prescribe exercise, and you prescribe the drugs. That is the take home message. There is no such one size fit to all treatment in diabetes is now. And ADA also now highlight the importance of patient-centered care, individual patient preference. Patient is involved in all clinical decisions. So we should not, we should tell the patient, sugar is not under control. Can we put you on insulin? Like that, we have to ask the patient, instead of we are pushing the patient towards the side. So always involve the patient in the treatment decisions. Thank you.
Thank you, sir. Any questions from the audience? Thank you, sir, for an excellent and enlightening session. Your expertise has provided us with valuable perspectives that will certainly enhance our clinical practice. I kindly request Professor Dr. Abhijit Basu, Department of Cardiothoracic Vascular Surgery, to honor the speaker. We are nearing the end of our program, and it is now my pleasure to invite Dr. Thambidurai David, Deputy Director, to express our gratitude with a vote of thanks.
Dear everybody, I take this opportunity to thank our father, founder father, Chairman, Chancellor, Most Reverend Father J. Arulraj, for his unwavering support in taking KMMC to a futuristic of research and scientific approach in medical science, who has been always encouraging us to incorporate the latest medical technologies in KMMC, including artificial intelligence and robotic surgery. I thank Reverend Father Baby Joseph, our Pro Vice Chancellor, for his enthusiastic guidance and encouragement in the field of research and scientific studies. Thank you, sir. I thank Professor Dr. Mohan, our Dean, for his rock-solid support in conducting such scientific and knowledge update events for the doctors and students of KMMC. I thank our medical superintendent, Professor Dr. Anthony David, and our Professor of Medicine, Professor Dr. Prince Pius, for their relentless efforts in making today's event possible. I thank our directors, deputy directors, RMOs, Reverend Sisters and Fathers of the DMA and MMA for their valuable support for keeping us marching towards a better tomorrow. I express my gratitude and gratefulness for all the honorable speakers who enlightened and updated us with the latest trends and practice in the field of diabetes. I extend my heartfelt thanks for all the esteemed delegates for gracing this occasion. I thank our professors, head of the departments, assistant professors, senior residents and junior residents for your bonding and cooperation, which makes us feel like one family here in KMMC. I thank our dear students for their eagerness and their natural interest in such type of vertical integrated learning programs. I thank all those who have taken the task of arranging this event which with much love and care. It was a very useful and memorable event indeed. I thank you all once again for the wonderful time. I thank the Research Society for the Study of Diabetes in India for partnering with this event. I especially thank the event sponsors, Habitat Healthcare Pharma, for making all this happen well today. I request Professor Pius to honor the Habitat Pharma people. From Department of General Medicine, we hope to meet you all soon again with such type of programs. Goodbye from all of us at KMMC. Thank you.
Thank you, sir. We extend our thanks to all of you for participation in today's CME sessions. Your active engagement and thoughtful questions contributed to a rich learning environment. Thank you. It's time for lunch. For students, lunch is arranged in their mess. For doctors, food is arranged beside this hall. Thank you.